Can we go?
Yes.
Hello? Yeah. Good evening, everyone. It's a pleasure and privilege to be here on this April evening. Indian time is 6 p.m. And I warmly welcome all my international colleagues who have joined to add the value to the proceedings. And I love to be in a physical meet, but unfortunately, things still, COVID is not completely gone. So we are holding the virtual. But I am lucky that my trust board has trusted me and extended my presidency for one more year. So next year, I promise all of you, the venue will be Hyderabad physical conference, probably at the same time, April around 10th, 11th, the second weekend. I request all my international speakers also to mark your diaries. Next year, it will be physical conference after the 2-3 years tumultuous COVID. Let's have fun in Hyderabad in a physical form. And I got great colleagues here who will be conducting the proceedings. And my great friend Arun, who is the doyen of Arthroplasty in India, and who has really put India on an international map as far as the arthroplasty is concerned, with his excellent insights. He has written great books and probably one of the most or the most prolific writer and scientific contributor from the Indian continent. Arun, welcome. And I hand over the proceedings to you. And Praharsha and Suhas, my colleagues, are there. They will also be aiding you with the proceedings. Arun, from now onwards, you are the boss. And Arun, you got it already. I can see the screen on here. 25 years of clinical experience. He is the director of Mullaji Knee Clinic. He has done more than 20,000 successful surgeries, 100 scientific papers in peer-reviewed journals, a wonderful accomplishment, 3,500 citations, collaboration with IIT Nanotechnology Lab, Bombay, and have 4 patents under review and 2 patents granted. He is the founder member and past president of the Indian Society of Hip and Knee Surgeons. He is the past president of the Asia Pacific Orthopedic Society, and is executive member of the Indian Joint Registry. This is a very small paper of accolades for Arun, and we all value him and his acumen. Arun, take over the proceedings and add as much value as you can. After Arun.
Thank you very much, Gurva, for the kind introduction. And I think without much ado, let's move on, because we have a real action-packed, exciting program with lots of speakers, a combination of international and national flavor, the young and the less young, more experienced people. So we have a real great combination of talks as well as cases and concepts to discuss. So without taking any more of your time, I'd like to bring in the first speaker, a keynote lecture by Professor David Barrett, who most of us know has visited us several times and is no stranger to India. And he's a very accomplished surgeon cum engineer and very well recognized in the international circuit in knee surgery. He's also a designer of several knees. And we've asked him to give a keynote lecture on compartmental arthroplasty of the knee. So let's have David Barrett.
Good evening, everybody. My name's David Barrett, and I'm delighted to be joining you this evening at the Indian Society for Hip and Knee Surgeons. I'm very grateful to my good friend and colleague, Arun Mullaji, for this invitation to speak to you. So, why compartmentalize arthroplasty? And you might say, why indeed? Because we actually have a very good solution right now. We don't need to do anything that is expensive and dangerous. So in many ways, you're right. These are demanding implants that perform well when skillfully implanted. So we're talking about PFJs, we're talking about UKRs. Now, they perform well. However, they don't perform well when poorly implanted by people who perhaps don't have the correct training or indications. And there is a higher revision rate for PFJs and UKRs. And they both often fail for technical reasons. And that relates to the surgeon, how the surgeon put them in, and that's the reason they often fail. You might say it's a recipe for disaster because we're taking the two prostheses that have the highest failure rates in the NJR, PFJ and UKR, and we're combining them. Okay, and you can see the survival rate for total knee way down there, and you can say why would we want to do this surgery? And the answer is we treat a spectrum of people. And there is no doubt that the elderly lady who is low demand, low function will be best suited with tricompartmental disease with a total knee replacement. We've done that for years. It's going to work well for her and she's going to be happy. However, we're seeing increasingly, and I know you in India are seeing this increasingly, younger patients with symptomatic arthritis who want to maintain their function and are not going to be happy with a total knee replacement. And so you might say, well, it doesn't matter. We're going to give them all total knee replacements. It always works. And it does work if you look at the data for only old people. If you look along now, with the younger age, we can see the NJR shows that they are going to have increasing revision. And so looking at our under 55-year-olds, they have 6 times the rate of revision of our standard elderly patient. And so we've known this for some time, actually. So this is a 2006 Scandinavian registry. The 64-year-olds have 3 times the revision rate of the elderly patients. And so there we go. 3 times the revision rate, exactly the same as the UKR. So suddenly compartmental surgery looks very reasonable because revising a failed total knee in a young patient is not as great as changing a unicompartmental. So straight away, this begins to make a little bit of sense. So what are the indications? And it's really based on the extent and location of the disease, the age, mobility and function of the patient. So if we look at this patient, you might say, well, I really don't want to do a total knee on him. He's got early disease. He can't play golf, but he can walk up to 3 miles. And so often you come to this decision about compartmental surgery by saying, I'd really like to do a uni on this patient. And so this would be very suitable for a uni. But the trouble is he has symptomatic patellofemoral disease. And so now you say, well, why can't I do a bicompartmental replacement? Why can't I resurface both areas? And so you can. And you can choose different implants. They don't have to be of the same company. You can mix the prostheses. You can use an onlay or an inset trochlea, a mobile or a fixed uni. You can use a dome or anatomic patella. Okay, and so this patient went on to have a fixed bearing medial and a trochlea resurfacing and patella resurfacing. He kept his cruciates and he kept his lateral side. And the attraction of compartmental surgery is you can match different requirements. So this patient needed bilateral medial medial implants and a lateral on the left side. So it doesn't have to be the same thing for everyone, depending on the requirements. And this particular lady has got bilateral lateral disease and needed patellofemoral resurfacing as well. So she needed 4 implants, which we're able to do at the same time. And so you can see how this straightens out her valgus deformity and deals with her patellofemoral pain. And so you have a decision about whether you might want to do this together or stage it. Whether you can clearly see that the medial and pat fem needs to be done at the same time, or whether you want to wait until the pat fem becomes symptomatic, or possibly do the pat fem much, much later if they develop differing disease. So you can see we're making up the surgery to suit the patient rather than trying to fit the patient into the one operation we can all do. So patellofemoral progression is sometimes a worry for people who do unicompartmental surgery, and that can happen whether it's mobile or fixed bearing. And so in some ways with compartmental surgery, we're future-proofing our surgery. So this patient of mine had a surgery in 2003 where he had a medial compartmental resurfacing. 11 years later, he's got no problem with the medial side, but he's developed patellofemoral pain. So we can go ahead and add a patellofemoral resurfacing. And so now he's happy, he's kept his cruciates again, and he's still got those implants now, almost 12 years later. So the surgical technique for these 3 different, if you like, combinations is much the same. So we'll always do the medial side first because we can balance that medial side because we usually have an intact ACL and intact MCL. And then we go ahead and do the lateral side because by choosing the thickness of the lateral bearing, we can determine the alignment of the knee, which is important in achieving the alignment and the balance. And so you can see it's quite interesting how we choose different implants for the different sides of the knee, reflecting truly the asymmetric nature of the knee anatomy, which of course we can't do in total joints because we're using a monoblock implant for the femur. And so you see on this picture, that's Whiteside's line up the middle, and you can see how on the medial side we're going to tilt that inwards a little bit to reflect the kinematics of that particular compartment. On the lateral side, it'll be absolutely parallel to Whiteside's line because the lateral side is perpendicular. You can see on the medial side, we'll move the implant in closest to the midline as possible, again to reflect the kinematics. Yet on the lateral side, we'll move it as far out as possible on the lateral side, again to reflect the different requirements. You can see the sizes are very different. We're using a size 1 on the lateral side, a size 3 on the medial side. You can see from the different color of the tibial spaces, we're using different tibial sizes, but also different thicknesses. So truly we are matching the individual compartments of the knee here, rather than just doing one huge implant. You can see on this particular case, we've added a trochlear as well because of the patellofemoral arthritis. So we've ended up with a tri-compartmental knee, both with cruciate sparing, both cruciates are present. And they still work. And this is, we'll be able to show this shortly, that we can keep that AP stability. And so this is, you can see the normal kinematics of a knee through a gait cycle in blue. It's a biphasic pattern. And that is replicated by UKRs in green because obviously you've kept the cruciates. The total knees, whether they're cruciate retaining or cruciate or posterior cruciate stabilized, are originally just a flat red line. They are not responding to the normal kinematics. Now, in a bicompartmental knee, a bicompartmental knee will resemble the kinematics of a uni, not a total knee. And Tom Hayes has shown this, that actually a bicompartmental knee behaves just like a uni rather than a total. And you may say, well, look, I don't think I see very many of these patients. If we look at a general knee population, as Heekin has done, we find about 25 or 30% of patients are suitable for a bicompartmental approach rather than a total knee replacement. And let's have a look at our results. And in Southampton, we've been following this tranche of patients for over 10 years, and with an average 7-year follow-up. And if we look at their Oxford and Womack scores, and you can see that comparing a multi-compartmental resurfacing with that of a total knee, both go into the study with almost identical Oxford scores of 20 for the total knee and 22 for the multi-compartmental resurface group. But if we look at our young patients and we quantify excellent results, we see the multi-compartmental in blue have got twice the number of excellent functional results than we have with the young patients in total knees. And this is borne out by other researchers in this area. So this is Yeo's paper showing that in patients with bicompartmental versus total knees, we've got more rapid mobilization, less blood loss, better function, and equal survivorship. So not the high rate of failure we've seen with these implants individually. Jerry Eng's paper has shown at least an equal and a trend to exceed in a matched pair analysis of bicompartmental versus total knee replacement. And this is perhaps the nicest paper of Seb Parat's, where he's taken a very powerful statistical study. So he's used a prospective match study cases. So they're matched together, total versus bicompartmental. And you can see he's looked at this in terms of KOOS, forgotten knee score, TUG, and UCLA score. So all functional scores, and fantastically significant differences in the functional outcome, bicompartmental versus total knees. And remember, this is what this young age group is looking for. So I think there's a real need for an alternative to a total knee in the patients that we're increasingly seeing nowadays with young, active wishes. We've got to look after these patients for up to 40 years as their arthritis progresses and as they evolve in different changes. So one operation age 50 isn't going to last them 40 years. And so compartmental arthroplasty means we can build that implant with the patient as they age. We've got data now over 5 years years, up to 10 years in some cases. And we know this is demanding surgery, but with good indications in case selection, with good surgical skills, and possibly with robot assistance, we will get a rewarding functional result. And so what we want to do is get a result like this, where you can see this patient's had a medial and fem on one side, a medial on the other, and you can see is wakeboarding. Okay, so think on this. I've enjoyed, hopefully, making you think on this, and I'm very grateful for the invitation to speak with you tonight.
Thank you very much, David. And we've got one question. Instead of doing bi-compartmental surgeries, medial and lateral unis, why not consider a bicruciate retaining total knee?
So, Arun, I think, hello, everyone. It's great to join you in person. I thought that lecture was absolutely, completely brilliant, but I guess I would, wouldn't I? So I think that's what we're looking for as knee surgeons. We know that without the cruciate ligaments, our knee replacements in this high demand group are often disappointing. And I think everyone recognizes that. So obviously by cruciate retaining total knees are an effort to address that. But it's almost the kinematic conflict, because you saw in that operative picture that I had different slopes on the lateral and medial side. I had different thicknesses of polyethylene, and the implant were tilted in different directions because each compartment is individual. Now, the trouble is we've got a tibial monoblock and a femoral monoblock with a bicruciate retaining knee. And I think that there's a kinematic conflict with what the ACL and PCL wants to do and what a monoblock total knee will let them do. So, Arun, I think it's because it's difficult to address the asymmetric nature of the knee that has to work with the cruciates in a monoblock implant. So you can see what the total knees want to do. They want to keep the cruciates. I just think it's too difficult with the anatomy that we have to recreate around the cruciates.
Arun, can I ask you a question?
Sure.
Yeah, David, that's a wonderful talk. But David, you got only 5-year term result. Am I right?
No, so sorry, I knew I would expect a difficult question from you. So it is true, we've got 5 years plus. Now, in some of our groups now, we're going out to 10 years plus. You're right. We need to look at long-term follow-up in this high-demand group. So what we've done is what the studies have mostly been at matched pair trials, so we can get a statistical significance in terms of function. But you're right, the longest follow-up is probably our group, which is now out to 10, maximum 12 years. And so you're right, we're not in that position of matching the long-term 15-year plus follow-up of the knees. So absolutely, let's watch this space.
Yeah. Arun, please let the discussion flow. Even if it overshoot by half an hour, 45 minutes, it doesn't matter. Okay? Because it's so much value added. So you be the judge.
Great. Okay. So what proportion of your cases would be non-total knee replacements in your arthroplasty knee patients? What proportion would be either unis or bicompartmentals or patellofemoral with a medial uni?
Sure. So, Arun, I think in a standard knee practice, in terms of what we do in partials, you're probably looking at between sort of 25, 30%. Okay. Now, I have a very much tilted practice because I have an interest in this. So people come to me. So I would do 250 partials or bicompartmentals, and I'd probably do 30 knees. So that's all wrong. So that necessarily wouldn't be applicable. But when we look at a general knee population in Europe, we're looking at 30% would be suitable. Now, I think that varies in different parts of the world, and I've had the pleasure of visiting India a number of times. And obviously, the cases you see are much more demanding and often much further extended. So it may not be that true in, let's say, rural India, but in your centers of population, you're having a lot more demanding younger population now, and I think you will see more of these.
And do you have any restrictions in terms of either deformity or the intactness and integrity of the ACL? I mean, how much damage to the ACL and how do you assess the ACL?
Okay, so I assess it functionally, Arun. So I don't believe that we need an MR scan because that can't really tell us about the function of the ACL. So if someone says to me, I'm worried about my knee, I feel unstable, it gives way, I had a sports injury 10 years ago and it's never been right, then I'm very suspicious about the ACL. I think sometimes at surgery, and you'll know this as well, we look and we see that the ACL is barely there and we think, how do they manage? But they don't have symptoms. And so I wouldn't worry about that patient. But the patient that has functional ACL instability, I then become concerned about doing a bicompartmental. So I think for these high performance needs, they probably do need their ACLs. But if they don't have a functional lack, I'm happy to do them. So it's basically on the history and function. I don't use an MR scan.
And do you modify your technique in terms of the tibial slope if you're a little doubtful about your ACL?
Sure, I don't, Arun, and that's perhaps wrong. And you could probably tell me what your thoughts are about that. But I feel that although that is from the world of osteotomy, and people will say in a revision ACL, I would change the slope, and we do this, we do that. I'm very conscious that as we change the slope of a uni, we're really changing the polyethylene contact pressures a lot. So suddenly this becomes a high wear knee with a wrong sort of slope. So I tend not to do that. I know a lot of people talk about it on the podium, but I'm very cautious about that. I'd rather do an ACL reconstruction.
Yeah, David, in the next decade, there more validity in India also, because we, coming up with the paper, we saw 4,000 total knees opened on the table and took a photographic evidence. And 40% of the knees are amenable for partial knee replacement, according to Oxford criteria.
Yeah, that's really interesting work. And I appreciate that because that's coming from a continent where we think that may not be. So that's a really wonderful figure. Thank you.
Yeah.
All right. So I think that was a fabulous opening batsman that we had from the UK, Prof. Barrett. And he's hit a few sixers while he's given this talk. And we're all grateful to him for having taken time out. We'll move on to the next speaker. And we now have Dr. Dhanashekar Raja, who's from the Ganga Center in Coimbatore. And he's now a senior consultant there and is one of the most academic youngsters that we can find in India. So we've asked him to tell us whether we need newer materials for femoral components in total knee arthroplasty. All yours, Dr. Raja.
Thank you, Arun. Thank you, Ish, for the opportunity. So do we need alternative bearing material for femoral component placement? I think Professor Dave Barrett also could add to this because a lot of recent work is coming from Southampton University. So total knee replacement is a very good procedure and gives excellent improvement in care for our orthotic patients. And the standard total knee replacement, well done replacement could survive 15 years at end of 15 years, 95% survival at 15 years. The failure mechanisms include aseptic loosening and implant wear, which are the most common cause of late failure. And late failure is due to wear and loosening, especially is more common in young male, obese and overweight patients. The newest epidemic is the periprosthetic fracture, which is also due to osteopenia around the implants. Femoral bone loss is due to three reasons. One is stress shielding, which happens behind the anterior flange and the distal articular surface of the femur. Osteolysis due to wear-released resorption between the bone cement interface, and implant loosening per se due to movement of the loose implants. So diminishing the stress shielding effect, improving the quality of polyethylene insert, and decreasing the rate of implant loosening will further reduce the aseptic loosening and improve the longevity of the implant. The stress shielding happens after a total knee replacement when you're using a cobalt chrome implant. When you do a DEXA after a total knee replacement, the bone mineral density is reduced up to 44% in the areas marked here. So the red is the high loading area and the blue and green area low loading areas. After a total knee replacement, we can see behind the anterior flange and distal femur processes area, you can see the blue area. The red area is where there is normal loading happening. So this is what we call as stress shielding. And stress shielding is directly proportional to the type of implant material used. So if you use a cobalt chrome implant, there is 44% reduction in the bone mineral density. So reducing osteolysis, we have new materials like highly cross-linked poly and antioxidant doped poly. And also a femoral component, we are using ceramicized femoral component and tibial component. So hypersensitivity is well described, and up to 12% of the wear particles, if you weigh the wear particles in the wear analysis, up to 12% of the wear particles is from metallic products, metallic ions released from the articular surface. In the Australian Joint Replacement Registry, 2% of the revision TKRs has been attributed to metal-related pathology, and patients having pre-existing hypersensitivity to metals always correlate the problems after total knee replacement to metal allergy. So need less metal sensitivity when you are thinking about femoral components. So what are the alternate choices? We need to reduce the wear, have a metal-free alternative, need to have a component which reduces the mismatch between the femoral bone and the implant, and have to improve the post-operative outcome. So if such a component is available, we can substitute the cobalt chrome with the alternative femoral component. So the materials available at present are ceramic or ceramicized metal. The new material recently launched in the clinical trial is PEAK. So ceramics has been used from 1972. It is biologically inert and has more scratch resistant, especially Biolox Delta is 10-fold less scratch resistant compared to cobalt chrome and 5-fold compared to oxidized zirconium. It has a very lower damage due to third body wear and lower wear on the poly. So it is not new, and alumina ceramic has been used in Japan. 15 years follow-up has been reported with the alumina tricompartmental bisurface knee system. Up to 94% survival has been reported. But there are incidents of ceramic fractures. Now they are substituting the alumina with zirconia from 2001. Another series from Nakamura have a medial pivot type of knee with a ceramic articulating implant, and the 10-year survival is almost 98.6%. The outside Japan, the Biolox Delta components, two components are available. One is the Multigen Plus, 107 patients implanted at 5 years follow-up. The implant survival is excellent. Other one is the BPKS from the Peter Brum. It's a total metal-free implant. Both the femur and tibial components are ceramic and has both fixed and mobile bearing options. And 38 implants has been clinical trial with 38 implants has been done. So far, the results have been good. So this is the review of literature comparing all the ceramic implants. 14 studies has been taken, and considering the survivorship is almost equivalent to cobalt chrome, and there is excellent, considering the excellent tribology of ceramics, there could be a promising long-term utility of ceramic implants. Next, we're coming to the most commonly used oxidized zirconium, where stimulation at 5 million cycles has shown that 85% reduction in the poly wear. And we can compare this cobalt chrome with the poly, especially with the cross-link poly, the wear is really reduced, volumetric wear is reduced. But we see the clinical results from the Australian Joint Replacement Registry, 17,577 processes. Comparing same design, oxinium with the cobalt chrome design, there is no difference in revision rate. Even if you rule out infection, there is no revision difference in the revision rate at end of 12 years. Even if you age stratify, because oxinium is most commonly used for younger patients, more active patient and obese patients and patients with metal allergy. They are selectively using more for this patient. If you age stratify and compare this patient, also there is no difference. But the problem with the Australian registry, it does not give you the alignment data, preoperative deformity data, all those other data. But overall, if you compare, there is no difference at end of 12 years. That means there is more, instead of material, there we need to concentrate on the design of the implant also. So a low wear design, a low conforming design could also reduce the long-term wear rate. If you compare the infection rate between oxinium and the cobalt chrome implants, this is again from the Australian Joint Replacement Registry, result from 326,000 odd patients. The revision rate of cross-link poly versus conventional poly is less, but there is no difference between revision rate of oxinium and cobalt chrome. So the oxinium does not reduce the infection rate. Though there is less release of cobalt, chromium, and nickel from the articular surface, it does not influence the infection rate. So next we come to coated cobalt chrome implant. The cobalt chrome implants coated with titanium nitrate has been used. A 3 to 4 micrometer layer of titanium nitrate is coated on the cobalt chrome. Biomechanical studies have shown that 98% reduction in the wear rate. So if you can see the surface hardness, the titanium nitrate has a better surface hardness. You compare the different material. Because of the increased surface hardness, the wear secondary to third body is reduced in titanium nitrate compared to cobalt chrome alloys. But the clinical results do not show major difference. You compare titanium nibonium nitrate with conventional cobalt chrome in Vanguard implants, there is no difference. Again, comparing next-gen LPS titanium with cobalt chrome at end of 10 years, the survival rate is 95.1%. So all these allergy-free metals that did not improve the longevity of the prosthesis. So next, coming to this paper is just recently accepted for publication in Journal of Orthoplasty, or really the nickel-free implants, or we are doing a nickel-free arthroplasty. So they measured the metal ions after before total knee and after total knee, pre-op, and then first day of after total knee. They aspirated the joint fluid and sent it for cobalt chrome and nickel analysis. So they used two types of processes: cobalt chrome implants and oxinium implants, the zirconium implants, and they measured the nickel, cobalt, and chromium level. So compared to pre-op, post-op, there is heavily increase in both nickel, cobalt, and chromium levels in cobalt chrome implants. But if you look at the cutting block and the saw blade, this contains high level of chromium and nickel. They don't have cobalt, but they have high levels of chromium and nickel. So if you examine the saw blade, there is loss of material from the saw blade. So there is release of cobalt and nickel during surgery. So even if you use the oxinium implants, there is almost 3.3 times increase in the cobalt chrome level after a TKR. Oxinium, so-called the nickel-free implant. It can be oxinium or any implant, ceramic. If you're doing a total knee, the cutting block and saw blade is going to release nickel, cobalt, and chromium, not cobalt, chromium into the joint. So these high-cost implants are going to be in question. So based on this newer study. Next, the new material recently launched for clinical trial is the all-polymer PEEK implant. It's a polyether ketone. The modulus and flexural strength of this is matching the bone density of the normal human bone. So it is radiolucent and it's very biocompatible. The wear debris does not cause any debris, does not cause biological reaction. The studies have been done at Southampton University, and recently a clinical trial has been launched. It is biocompatible, CT compatible. We can see that the wear is not too much, and dynamic loading and linear scratching does not increase the wear. This clinical trial is under process, and we have to wait for the clinical results. So in conclusion, arthroplasty surgeons have a lot of implant at their disposal of different shapes and size. In vitro results do not translate to in vivo situations. Still, the most important feature for survivorship: well-balanced, well-aligned, and well-fixed implant. Thank you for the opportunity.
Thank you very much, Dr. Raja. I'm not sure that there are any specific questions that have been addressed to you, but I'd like to ask you one thing now. What is your answer to the question that we posed you? Do we need new implants, and do we have safe new implants available?
So there are two aspects of this question. One is how to increase the longevity. Can we do alternative bearing, increase the longevity? So for that, we need to have some implant which is less of stress shielding. So the PEEK newer implant which is launched is the polymer PEEK, which has more less stress shielding compared to cobalt chrome implant. That is one aspect. Second thing, the wear characteristics.
Let's make this more interactive. I mean, how often between all of us, we must have done probably a few lakh total knee replacement. How often have you seen the femoral component loosening out and being revised?
Very rare.
That's very uncommon, right?
Very uncommon, yeah.
Extremely uncommon. And even in the literature, everywhere, it's spoken about loosening of the tibia. Very rarely are we encountering cases where the femoral component has loosened out, except for certain design problems, like there were some high flex knees where they resected a large amount from the posterior condyle, and those were known to fail. But from either wear properties, causing stress shielding and osteolysis from the femoral side, I mean, how often have you seen that?
So it's very uncommon. The femoral loosening due to wear and stress shielding is less common compared to other problems like tibial loosening due to wear and malalignment, other technical problems rather than femoral loosening alone. So the need for changing the femoral component is not as high compared to other things like technically done surgery, proper alignment, all those bearing material. So
let me ask you, if you were to have your total knee tomorrow, what femoral component would you use?
So the paper I quoted just before, are we really doing a nickel-free implant? So always I was thinking instead of cobalt chrome, I would have an alternative nickel-free implant. So, but the question is the cutting block and saw blade are releasing so much nickel into the joint. The question of nickel-free implant is totally gone. So I will still stick to a well-proven cobalt chrome with a good, well-designed knee and a good surgeon. Material may not have...
Okay, great. Thank you so much, Dr. Raja, for that very candid conclusion. And it's my great pleasure and privilege to invite our next speaker. And he's coming all the way from Montreal in Canada, and he's agreed to be to present live. And we are very excited to listen to him. He's received a whole host of awards from very prestigious societies. And he is now the founder of the Personalized Alignment Society. And he's going to tell us why we need to personalize alignment in total knees and not put them all at 90 degrees. So, Pascal, Andre, it's all yours.
Thank you very much. So I'll try to share my screen. Perfect. Okay. So it's a great pleasure to be with you tonight. First, I think probably the only positive fact of the COVID pandemic is I can be share with you this presentation from home. So what is the role of personalized alignment in total knee arthroplasty? My disclosures. I believe that native human knee is more performant than any reconstructed knee joint first. And I know that individual human knee anatomy is unique and its specificity relates to its natural function. So let's have a look at what is patient anatomy to better understand the, let's go back here. Okay, so we know that from a 4,800 CT scan of patient waiting for total knee replacement, that the mean HK is about 0 degree. But look at the data spreading, varus, valgus. So there is a real number of patients that are away from that 0 degree. If we look more in detail, the anatomy of the femur and tibia, just in the frontal plane, we have a mean value of about 3 degree valgus for the femur and 3 degree varus for the tibia. And again, look at the data spreading for both bones, only in the frontal plane. If we had the soft tissue in this equation, there is a high individual variability. Women are more lax than men. Collateral ligaments are not isometric. MCL is tighter than the LCL. And both collateral ligaments are tighter in extension than in flexion. If we combine the soft tissue with the joint surface, it will create a very specific femoral-tibial kinematic, and it was described as a medial pivot kinematic, as you can see here, by the Denver group and Freeman. The medial compartment stays center most of the arc of motion, and the lateral side, you see a translation of the femoral condyle posteriorly, almost subluxating the lateral meniscus. Combination of these articular surface orientation, ligament laxity, the flexion axis will create knee kinematic. Now, what will happen with our surgical technique and the implant design. This were the discussion for the first two presentation, that what we're doing as a surgeon will change knee function. Any changes in the bone anatomy will create imbalances because we're changing anatomy. As you can see here, in 1,000 CT scan, we simulated mechanical alignment, and the imbalances that we create were up to 20% in valgus knee above 5 millimeter between medial and lateral compartment, and the varus knee 7%. So these imbalances are very hard to correct with soft tissue release. If we look in flexion space, very similar results are obtained with transapicular axis alignment or 3-degree fixed external rotation with mechanical alignment. You can see here imbalances above 3 millimeter that reach up to 60% of the valgus knees. And if we look at the joint line orientation, just in the frontal plane, this is an example of a mechanical alignment total knee implantation, and compared to patient anatomy pre-op, we inverse the joint line with our surgical procedure. And if we look in the 3D dimensions, we change the whole flexion femoral axis of the knee joint. What will happen? What will be the effect of these systematic technique and these anatomical changes that we're doing with total knee for years? 75% of our patients do not experience a natural knee joint. And it was the purpose of the presentation of Dr. Barrett that we try to find ways to improve patient perception, the feeling of a normal knee joint, reduce the residual symptoms. With mechanical alignment, total knee, we have 50% of the patient who are not that happy with their knee joint. So there is room for improvement. If we look in Gait labs, these anatomical changes have a direct effect on the kinematic of the knee, decreased range of motion, decreased flexion at heel strike. So people do not walk as they should be with a normal knee. What is the solution? I mean, we should go back to the start, look at patient anatomy with dynamic MRI, understand the knee kinematic, and the solution appears to be a personalized alignment. So we should try to avoid any modification of each patient anatomy. So in the last 40 years, TKA with mechanical alignment survive, but I think now it is the time for a change. We should change from systematic approach to a personalized surgery. And with Dr. Charles Rivière, one of my great colleagues, we published an editorial a few years ago saying that now it's the end of the era of mechanical alignment. What should we do now? We should do a knee resurfacing of the joint. What is a real knee resurfacing? We remove a thickness of bone and cartilage that equals the thickness of the implant that is put in for the distal femur and posterior condyle as well. So as you can see in this animation, we are replacing the bone we remove with the exact thicknesses of implant. The same will be done on the tibial side. And this is really a simple concept. Kinematic alignment technique is simple. It's not complex. If it's a bony procedure, we don't want to modify ligament laxity. So there is no ligament release unless the ligaments have been modified with the disease. Should there be limits? Is there some pathology that we should not reproduce? This is my personal belief, and I'm promoting a restricted kinematic alignment protocol for the last 11 years, because I believe that some patient anatomy are pathologic and should not be compatible with an implant. So I would suggest, if you're interested, to read about the restricted concept of kinematic alignment, to read the 5 principles and the fundamentals I published in Frontier in Surgery recently, where you can find this simple algorithm how to decide which patient you should correct and keep within a certain boundary of ISHKS plus minus 3 degrees and a femur and tibial cut of a maximum of 5 degree orientation. Now, there are some very severe cases that you might see in India with severe valgus, severe varus, bone loss, ligament laxity, and these specific cases are not that frequent. They're probably 10% of your practice, maybe a bit more. And we published with Dr. Rivière a paper in Effort Open Review where we try to address these specific cases. And then I would encourage you to read this good paper. So in summary, human knee anatomy is variable. Any change in patient bony anatomy would translate in soft tissue imbalances, flexion axis modifications, kinematic impairments. So we need to try to follow what is the best option for the patient. We are moving from systematic technique like mechanical alignment, where we put all the eggs, whatever their size, their color, in the same basket, one size fits all technique, to some a bit more specific alignment like anatomical alignment. The basket looks nicer, but it's still a systematic technique. Transitional alignment, now try to create some subgroups to a real K technique where each patient has its own individual alignment and knee anatomy. The result of such a personalized surgery, I would share with you a very recent meta-analysis that was published and showed that K technique in analyzing all the results of randomized control trial achieved better functional outcomes and in terms of key SS and WOMAC score and knee flexion range. So this is really a game changer for the patient. We are improving their function, their satisfaction with knee replacement. I suggest, if you haven't done yet, to visit our website, personalizedarthroplasty.org. It's the Personal Arthroplasty Society. I am very proud to be the founder and actual president of the society with my colleagues, Dr. Bini, Michael Hirschman, Charles Rivière, and Stephen Howell. And on this website, you can find the Personalized Arthroplasty knee joint replacement book, which is free access. Thank you very much for your attention.
That was wonderful, Pascal. It's really quite an eye-opener for a lot of us who've been using a mechanical alignment for many, many years. And on the other hand, we find that kinematic alignment seems to be a little excessive for a large number of our patients because they have so much of distorted anatomy. So my question to you, Pascal, is in theory, it sounds very great and very simple that you put in what is, you take out what you're going to put in and you factor into that how much bone loss has occurred because of the arthritis. The key problem is assessing that in the distal femur and in the proximal tibia. How do you know how much of bone has been lost? So you can, if you have an MPTA of 83, for example, right, on the tibia, how do you know whether to restore it to 85, 87, 88?
It's very interesting question, and to really understand how to do it, best is to do cases with somebody who's expert in the field, and then to see the tricks. In every knee joint, there are some zones where the cartilage and bone is intact. So if you take a medial condyle or medial tibial plateau, there is always a zone of bone defect where you have cartilage loss, bone loss. But if you look at the entire surface, you can always find a zone where it's quite well preserved, and you should rely on this zone to decide what is the pre-arthritic joint surface. And this is present in most cases. Very rarely I would be stuck with a knee that has a complete destruction of the medial condyle or medial plateau in a varus knee. And this is the purpose of the paper and effort review, to give tricks on how to manage these very rare cases. But in most other cases, I would say it's quite easy to find where was the pre-arthritic joint surface.
What about on the distal femur? Because you have the same issue there. Because it's a convex surface, you've lost out a lot of bone on the distal, on the medial femoral condyle. So again, it's a matter of judging where are you going to restore your MLDFA to, whether you're going to bring it down back to 87, 85, because they're unlike on the tibial plateau, where you could have 2/3 of wear of the cartilage, and maybe the posterior 1/3 you have some cartilage to indicate to you how much to resect. On the femoral side, because it's a convex surface, you more or less become a flat distal condyle. So how do you assess that?
Yeah, multiple way to do it. If you're using caliper technique, you know that cartilage thickness in a small woman would be 2 millimeter, and a big man 3 millimeter. So first, if you have a full cartilage wear, you could use shims to compensate this cartilage wear, 2 millimeter in female, 3 millimeter in man, and then you can reconstruct the distal joint surface. If you have bone loss, then you can increase by 1, 2, 3 millimeter more the thickness of the bone loss that you can estimate. So this is easy, and if you use computer navigation, robotic surgery, you do the same, but with computer simulation, using the software provided by the precision tool. You need to see it to understand how easy it is. I understand that in theory like this, it's hard to imagine, but in practice, it is easier to do a K knee than doing a MA knee. And from experience, that's my feeling.
Arun, can I?
Yeah, Gurva.
Yeah, Pascal does a wonderful talk. In fact, I'm the member of your group, Personalized Arthroplasty. The last 2.5 years, we bought the Mako, and with that, our horizons are open. And now we are doing almost like a restricted kinematic or functional alignment. And there is no doubt in my mind, in 3 months, the outcomes are excellent. The robotics vis-a-vis the mechanical aligned knees. In the terms of flexion, in the terms of pain-free movement, in the terms of natural feeling of the joint. I'm not going into the nitty-gritty of these things, but with the robotics, we are now at freedom to do the non-mechanical alignment, even in the gross deformities. And we are really having a good outcomes.
Glad to hear that, Gurva, because we've been doing it with computers for many years.
Yeah, absolutely, Arun.
Any tool which can guide you, you can modify your cuts a little bit. That's the advantage of conventional instruments. If you're moving away from mechanical alignment, then yes, you need one of these tools.
Yeah, exactly. Shall we ask Dr. Pascal the same question? If there is no robotics or navigation, is a normal surgeon also can go and marry the kinematic alignment?
Yes, it was proposed by Stephen Howell to use the caliper technique, which is very, very accurate. The only downside of caliper technique is that you cannot do a restricted protocol, because when you resurface the joint with caliper technique, you have no feedback of what is the final alignment of your lower limb. So it's the only downside, but then it costs nothing and you don't need precision tool if you follow a true kinematic technique with caliper instruments.
Arun sir, can I ask one question, sir? This to Arun, sir.
Yeah, Parin, go ahead. Arun. Yeah, Parin,
Sir,
go ahead.
my question is, sir, you are using this computer navigation since long. We are learning from you. So, how much percentage of your present alignment is kinematic alignment, or you are still married with mechanical alignment, and why?
We gave up mechanical alignment a long time ago. We personalize the alignment to the patient's anatomy. We are measuring a great deal on CTs and on X-rays, and also seeing with navigation what is the present slope and the angles, and modifying our cuts accordingly. But we are sticking to up to about 3 degrees on the femur and tibia, so that, let's say in a varus knee, we would aim anywhere between 177 and 180 HKA in a varus knee, rather than going beyond that. So we are modifying it, but not to a great deal, not to the extent that Stephen Howell does, where he would slope the tibia even up to 7-8 degrees on the tibia, and he'd accept almost any angulation on the tibia. So I'm a little skeptical, because I think our bone quality or prevalence of osteomalacia, osteoporosis, etc. is pretty high. So we have seen a lot of failures on the tibia with even 2 or 3 degrees of malalignment. So we don't know whether we are ready for this or not.
For tibial side, sir, are you concerned about our weight, patient's weight?
If you're asking me the question, I do 100% of my patient with restricted K, and I'm 95% now uncemented. Even the elderly woman, obese male, so there is no limits on weight, age, and if you believe in the principles of kinematic alignment, load in the natural knee is favorable. So if you,
what is the implant you use?
I'm using different implants, but mainly uncemented is the Stryker Triathlon uncemented knee.
You use uncemented with macro robotics?
No, I'm using computer navigation, standard navigation. And we published the 5 years results of these patients, I think last year. So great osteointegration, great result. I did cemented most of my cases before, so I don't see a big difference. And the load in the knee joint, if you respect anatomy, should be optimal, because before the disease, these patients had normal knee function and normal knee loading.
All right. I think in the interest of time, let's move to the next panel. And I thank Pascal Andre for being with us, for taking time out, and for enlightening us with this very exciting new development in knee arthroplasty. So with that, I hand over to Dr. Ravi Kumar, and he's going to manage and moderate the next session, where he has an expert panel who I believe are all present now.
Yes.
They are going to discuss challenging cases in knee arthroplasty. Over to you, Dr. Ravi Kumar.
Yeah, thank you, sir. Good evening, everyone, and good evening, Ishq.
Should somebody share?
Can admin allow me to share the screen, please? Yeah,
Dr. Ravi, you can, Sharon Patil is away for some unavoidable circumstances. So Ravi has kindly accepted to chip in.
Yes,
I invite Dr. Suhas from Sunshine Hospital, Hyderabad, Dr. Neeraj, Dr. Mrinal Sharma, and Dr. Parin Kantisaria to take the panelist chairs. All of them are there, right?
Yes.
Ravi here, sir. Right, Ravi, go ahead.
Yes, sir. Thank you, sir. Dr. Suhas, Dr. Neeraj, Dr. Mrinal, and Dr. Praveen are the panelists. Let's start with simple knee. She is around 65 old with arthritis on both sides, painful, restricted daily activities. What will be your choice? I'll start with Dr. Mrinal.
I think it's a straightforward varus knee on both the sides, and if the patient is willing for both the surgeries together, I'll go in for a CR knee in such a patient. obviously with preoperative assessment of the deformity, whether it's a fixed varus or a correctable varus, whether the ligamentous integrity is okay. And after that, you can go ahead and do a straightforward knee in this case.
Okay. How about uni?
65 years of age, bone on bone medial side, lateral laxity. I think there is a little bit of patellofemoral arthritis also developing. I would go for a total knee rather than a uni. Okay, Dr. Suhas,
is uni is not indicated, or as Dr. Minal suggestion, we should go for total?
So uni will still be on the cards because the age group is amenable to uni. We would go in for surgery with both options at hand. And if we have an intact ACL, if the lateral wear is not there, little bit of patellofemoral wear is still acceptable. But an intact ACL and if there is no wear on the lateral side, uni can still be done in these patients.
Okay, doctor, for the audience purpose, do we need to do any special X-rays to detect ACL integrity in this case?
More than ACL integrity, I think the Oxford series is well established, where you do a valgus stress as well as a varus stress, and then a lateral view. Okay. These are more than enough for you to decide. The integrity of ACL, as we've discussed prior, is more of a functional assessment.
Okay, so that's the case. Okay, so let's, Dr. Neeraj, for audience and everybody, what should be the order of release in a simple varus like this?
Yes, it's typical straightforward varus knee. Here, if we are going ahead with TKR, whether it is a CR or PS, it is a surgeon choice. CR also can be considered because it is not severe varus here. And whether it is a subvastus approach, anteromedial arthrotomy, again, surgeon choice. I normally practice anteromedial arthrotomy, and then we release the medial structure, deep portion of the MCL to begin with at the time of arthrotomy. And then sequential release is necessary, as once the basic tibia cut is done, post that distal femoral cut. So again, it is a surgeon choice whether to go for femur first or tibia, but tibia and femur, post that we check the extension gap, then we assess the tightness, we take out the osteophytes, release the structures on the medial side. Once we are sure about the extension gap, it is balanced nicely medially and laterally. Then the same spacer, we check inflection around 90-degree flexion. And then once the femoral cuts, based on the tightness or the in the medial structures in the flexion, we decide the external rotation for the femur. If it is too tight knee or relative more laxity, then we might increase the external rotation based on the tightness on the medial structures. So I go ahead with the osteophyte removal first and then release of the soft tissues, because invariably once you remove the osteophytes, the medial side opens out. So don't be over aggressive while releasing the soft tissues to begin with. And sequential release is what is required.
Yeah, balance the knee in every step of the knee replacement is what you're saying. Yeah.
Yes.
Yeah, that's great. So this was straightforward knee, and it was like around 10-11 years ago. We did the mechanical element measured resection technique. Anybody doing restricted alignment in this group, in the panel?
I'm using ortholine navigation, so I do a bit up, but my concern is up to 1 or 2 degree, not more than that.
Okay. So
one thing I would like to just add, it's a simple varus, but my choice will be UK. But only thing is there is tibia vara.
Yes.
So what I have found is in tibia vara, be prepared that the release you require in a normal tibia, here it may be bit more.
Correct.
A varus with a tibia vara will require a bit more release. That's what I have found.
Got it. So, and also there is a bit of lateral opening, and medial release is essential in this case. Yeah. Thank you. This was our Gait cycle, and we did a simple knee. simple bilateral knee with a all poly component. It's around 11, 12 years post-op now. She's doing extremely well. So we'll go to the next case. Here is a gentleman around 60 plus, gross varus, and he is having extreme difficulty in day-to-day activities, and this is his X-ray. Dr. Suhas, can you take this case, please?
Suhas, we are unable to hear you.
Dr. Neeraj?
Yes.
Yeah, this is a gross varus with almost medial condyle loss.
Yes.
What should be our planning? How we should prepare? And what all, armamentarium in terms of implants, techniques, what should be our pre-op preparation?
So Suhas was saying something.
Yeah, can you hear me now?
Yes.
Yeah, yes, Suhas.
Oh, great. Yeah, so as I was saying that the clinical exam is very important. Whenever you see the telltale sign of a small piece of bone with an amount of bone loss, usually this bone loss is more posteromedial, the defect. So I would first see whether there is an associated FFD in these patients clinically. Number two, the correctability of the amount of varus deformity. And we will again reassess that after the anesthesia. In terms of the implant availability, I think we would go the full spectrum, everything from a CSPS to a constraint knee is important in these patients.
Yeah. Anybody who can try primary implants, or Dr. Minal? Yeah.
Yeah, I think you should also rule out Charcot's disease in such patients, because sometimes, although they develop stress fractures, I have had one or two cases where they had Charcot's, and the primary knee, if you put in a component, it's bound to fail. So if they are having sensation loss, or they are diabetic with uncontrolled diabetes and all, or with neuropathy, you must rule out those things in such situations with gross varus with the stress fractures, because when these patients, they develop these stress fractures, sometimes they are painless. And if that is the situation, then the scenario changes. For such a situation, I would obviously go for a constraint implant, build up the bone defects, use a stem extender on the tibial side, take a minimal tibial cut, do the releases, and then try and put in a PS knee, and always keep a constraint implant ready on table.
What are the chances of this being a neuropathic joint in your own experience, all the four panelists?
Very rare, sir. This is typical Indian village patient, sir.
Yeah, absolutely. There is no neuropathic joint comes like this. Neuropathic joint is where you have to diagnose on a radiological. It has to completely sublux in the lateral picture.
This is just because of economy, sir.
That's what it is. Exactly. It is not a neuropathic joint. The neuropathic joints, invariably, the lateral side, the subluxation will be there because all the ligaments, supporting capsule, everything is gone.
Sir, only thing I would like to add is these will require a popliteal release most of the time in flexion, because such subluxation will have only varus where popliteus is required to be released. So be prepared for that. That's what it is.
Yeah, I agree with that. Yeah. Okay.
Yeah.
Ravi.
Yes, sir. Yeah. Anybody? Yes, definitely we have to prepare with all the type of implants from PS to complete hinge knee. Any intraoperative, any intraoperative findings change our decision to shift from semi-constraint to constraint. Dr. Praveen?
Oh, sir. My choice will be, sir, PS with a tibial stem or SOS medial wedge, at least in right.
Yeah. In this case, what I wanted to highlight is we also aim to do a semi-constraint maximum and do a metaphyseal sleeve or something. But unfortunately, the ligaments were completely calcified. The ligaments were calcified. The medial collateral ligament was completely calcified. There was no option other than completely resecting it. So that's why these severely degenerative arthritis with neglected arthritis, we should keep that also in mind. We had a hinge on the shelf. We did total hinge, and yeah, he's doing well now. It's 11 years now. Guru sir, can I go to next case?
Yeah, good.
Yeah. So this is his follow-up. He is doing well. The opposite knee also we replaced. I didn't put the video of that. Yeah.
Yeah, if Arun is still there. Arun, are you still there? I think we'll.
Yeah, very much.
Yeah, Arun, do you want to add any holes of the previous cross arthritic knee? 1, 2, 3, 4.
Yeah, so that I would still try and get an MRI if possible in that patient, because I would suspect that MCL is intact. Calcification of the MCL is very, very unlikely. What is happening is that there's adherence of the osteophyte to the MCL, and you may be able to actually peel off all that medial bone from the MCL, and you'll find that it's actually very stable if you're able to dissect it out. And in which case you might not need any degree of constraint. Very rarely is the MCL actually destroyed in a varus knee. If you do, and we've done several thousand MRIs, which we are about to publish, the MCL is intact in all of these cases. Even in these horrendous gross deformities, there's no reason for it to have got damaged.
I agree. MCL seldom goes out unless it's iatrogenic. Yeah.
Here, the only real issue is dissecting it out, and secondly, fixation on the tibial side. So if you have a sleeve stem combination on the tibial side, you can take care of fixation. In terms of constraint, most of the time you won't need a constraint, because if you can preserve the MCL, you can get away with a PS or maximum
TC3.
TC3 or a CCK.
Yeah. Right, Ravi, go over to the next one.
Yes, sir. So it's a valgus, correctable valgus on the right side. This is a scanogram, and this is the varus valgus. This thing. She is around 67-year-old. What should be our approach, and any clinical consideration, choice of implants, and type of method of balancing? Dr. Mrinal Sharma.
I think it's Dr. Ranaval's type 3 valgus, where there is medial stretching of the ligaments, and we need to do the lateral releases. And I would personally like to put in a hinge implant in such situations, or a constrained implant, not a hinge, a constrained implant, because we have seen over a period of time in such cases, if you don't put in the constrained implants, usually the medial side stretches over a period of time. So although it's a correctable valgus, you don't need to do too many releases, but still, if you put a constrained implant, it is better in such situations.
Dr. Suhas?
Yeah, a valgus knee is a completely different beast. The 4 or 5 things that you need to know before you go ahead and operate these patients is, one is whether your valgus is correctable or not, number 1. Number 2, the integrity of the medial collateral ligament. Number 3 is whether there are any associated deformities like an FFD or an hyperextension or any extra-articular deformity. And the 4th one is we also should look at the foot, because sometimes if they have a flat foot, they'll still walk with a lot of valgus thrust. So these are the points that will help us in making our decisions. In this patient, I would open this knee just like a regular parapatellar. Definitely look at the medial integrity of the MCL, and if that is intact, we would do everything possible to do releases on the lateral side. The order is pretty simple. We would first look at the posterolateral corner, right from the popliteus up to the lateral collateral ligament. If you have any residual tightness in extension, you deal with the iliotibial band. And once these are done, flexion is usually just, you just have to match what you get in extension. And usually it is the popliteus that needs some amount of release. So I would try to put the least possible constraint, give him the best possible stability in these patients.
Yeah. Anybody worried about patellar tracking in this case? Any special consideration has to be done?
Don't think so, but once you give proper rotation, I think it should be fine.
So the important point there is, if you go by measured resection techniques where you rely on bony landmarks, there is a tendency to internally rotate the femur because of the bony landmarks. Usually valgus knees which hyperextend like this, I think gap balancing technique is a little more amenable in terms of rotation. If you're having to do any release on the lateral side, you've definitely internally rotated your femur.
So if we are like a major resection guys, so what special advice you want to give to get a proper external rotation? Like the valgus is like if you balance an extension and if you size the femur perfectly, the flexion is managed. So here, what should you advise?
Yeah.
What I usually do is parallel to tibial cut. That's what I have learned from Guru Reddy sir.
Yeah.
Always whenever in dilemma, rotation has to be parallel to tibial cut.
Yeah, I would second that. The posterior condylar axis is definitely unreliable. The white size line as well as the TE axis is still, but I would definitely use more than one landmark, one or two bony landmarks in order to rotate my femur in these patients.
If it is a correctable valgus, Ravi, as I always do, it has been described also. You cut the tibia first perpendicular like a mechanical axis, and you cut the distal femur parallel to the tibia. Whether it is 3 degrees, 4 degrees, it doesn't matter. You just make a diathermy mark on the distal femur and try to match that. And so that is the easiest way to do the valgus, correctable valgus. But if it is a fixed valgus, there is an entirely different one. Yeah.
I like to add here, also, Ravi. In varus, most of the cases, defect will be on the tibial side, but in valgus, it is the posterolateral femoral condyle, which is the deficient in many cases. So posterior condylar axis is maybe you can follow in varus knees, but valgus, it is unreliable. Epicondylar axis, again, which is reliable. And most of the cases in valgus knees, the posterolateral femoral condyle resection will be minimal because of the bone defect. As far as the patellar tracking is concerned, you had mentioned, but in this valgus knees and fixed valgus knees, there will be contracture of the lateral patellar retinaculum, and which definitely affects the patellar tracking. And even if your rotation is right and femorotibial placement is right, in some cases you will need lateral release to get that tracking right in place.
Yes, sir.
Ravi, can I disturb?
Yes, sir. Please.
Ravi, I think for our valgus knee, I think very important we are missing is the skyline X-ray for the other junior surgeons. The skyline X-ray is mandatory for these patients.
Yes.
The reason is if you have got a dislocated patella on the skyline at 30 or 60, you can't do a medial approach because that will require extensive lateral release to align the patella. So that is the case where you need to do what is called Cablish approach for these patients.
Okay.
And there's one more small thing, a trick regarding Arun said medial ligament does not get calcified. I totally agree. The only trick of remove that osteophyte is use 15 number knife. Do not use the cautery. Otherwise, you will damage the medial ligament. The medial ligament. That is one of the important thing which was missing.
Sir, can I differ with Dr. Pachure?
Go ahead.
Yeah, even if the patella is dislocating, I don't think we need to go lateral approach for a valgus knee. You can extensively release lateral side, doesn't matter.
No, that's what I told you. You will require a lot of release. That is the reason I told you.
Yeah, that's what it is. Yeah.
Too extensive release required. But that is the...
Yeah. But Ravi, go ahead.
Yes, sir. We just did 1 minute, sir. Sorry. Yeah. This was a correctable valgus, sir, almost. So just straightforward knee we did, balanced it in extension plus. Then as they were telling, the posterior lateral osteophyte was removed, and we were able to get with the PSD, sir. And this was the release we did because after everything the patella was not tracking well, so we did a cruciate form of release. Then the tracking was absolutely fine. So I'll go to the next case, sir.
Yeah, before that, because let me ask, Arun is here, we should use his experience because he has published a lot on the valgus knee.
Yeah.
Arun, quick answer. Fixed valgus, what is your algorithm? Which steps you take, 1, 2, 3, how do you go and release?
A lot of measurements are made first. So that we want to see whether the distal femoral condyle on the lateral side is hypoplastic.
Yeah.
If that is hypoplastic and you have a rigid valgus knee, see, these correctable valgus knees are not a problem.
Yeah, uncorrectable. Yeah.
We are talking now about a rigid valgus knee.
Correct.
If there is hypoplasia of the distal femoral condyle, then your options would be to if you want to achieve reasonable correction, close to 180, okay? If you're going to do a kinematic alignment and leave them in 4 or 5 degrees of valgus, then you don't have a problem. But let's say you want to get it to closer to 180 and you're trying to correct that deformity, then you have only two options. Either release the lateral collateral ligament from the epicondyle or release the epicondyle from the femur and distalize it. So most of the time we would rely on a sliding lateral femoral condylar osteotomy for a rigid valgus deformity, particularly if there's a hypoplasia of the distal femoral condyle.
Sir, what's your threshold for the osteotomy? Arun sir.
You should be Arun Mullaji. That is the threshold.
When we navigate, we see what is the extension gap differential between medial and lateral side and the valgus alignment for a balanced knee. So my cutoff is 4 degrees of valgus. So if it's going to be 5 degrees, 4 degrees or more of valgus, and I have a balanced joint, then I will do a sliding osteotomy and get it less than 4.
Sir, does osteotomy, do you believe, will give better advantage in peroneal nerve preservation in fixed valgus?
I don't think that there is a connection with that. It's more whether it's a flexion contracture or an hyperextending knee. If it's a flexion contracture, then you've got to be very careful because when you correct it, the nerve will be stretched. In those cases, if there's a severe stretch, then it's better to do a fibular head osteotomy, subperiosteal osteotomy of the fibular head and resect it so that decompresses the nerve. But that's very rarely that we have to do it nowadays.
Okay, so thank you.
Very good.
Sir, one second, sir. I'm just sharing the slide, sir. So I got disconnected in between. Yeah. No.
How many cases you got more?
3 more cases are there, sir.
Okay, good.
I can skip the valgus and go to hyperextension if you want.
Yeah, sure. You have done one valgus, one varus.
Yeah.
Go to the recurvatum. Yeah.
Yes.
Maybe just one case of hyperextension and then we can move on.
Yes, sir. I'll just. Yeah. Yeah. She is 1 minute, sir. Yeah. Sorry. Yeah. Yes, sir. 56-year-old teacher, non-polio, no neurological issues with any of the issues which can cause hyperextension, comes to us like this, valgus on one side, and these are all this much hyperextension on one side. Similarly, on other side also. Yeah, this is on the right side. Yeah, and this is the correctable valgus. This is on the other side where you can see, and this is how she's locking in hyperextension and walking. Yeah, these are the X-rays, sir. Can I open it, Dr. Parin? What should be your implant of choice? Is 56?
I will keep from primary to most. I will never keep hinge, but I will keep at least constrained knee. But my first choice will be primary only, because as you can see in the lateral view, there is loss of distal condyle. So hyperextension is, I think, because of 2 parts. One is natural, maybe hyperlaxity, and maybe because of some distal femoral bone loss. So I will cut less, and I think I will be able to do a primary.
Dr. Suhas?
Yeah, so as you can see here, usually if it's not neurological, so the hyperextension isolation is very rare. So usually it has, usually it's with valgus. So in this case, because we are able to correct, it's a correctable deformity. we would try to distalize the femur as much as we can. Of course, there's a threshold because you don't want to distalize the joint line too much. Okay. So do at least 3 to 5 mm, beyond which the collaterals start getting compromised in terms of the kinematics. And again, on the tibial side, we would raise it as much as possible and take minimal cuts. So flexion again is not of much worry as compared to extension. Constrain implants in these patients because if the integrity of the collaterals are there, we don't have to worry much. So post trial is where I think we have to make our decision whether to move further in terms of constraint.
Okay. So anything, any other panelists can add to the audience, like anything addition to be done or any investigations to be done, or
I think non-neurological hyperextension with the valgus are easily, addressed with the techniques which have been told. You cut less of distal femur, increase the flexion gap, do the regular balancing, and you might not need to use a hinge if it's not a neuromuscular disorder.
Okay. To be specific, question: what should be your DFC? How much distal femur cut you want to take? I mean, is it conventional 9 mm or you want to decrease? If you want to decrease, how much you can decrease?
5 to 6 mm.
Oh, maximum 5.
Okay. Got it.
But individualized depending on the amount of laxity, but this will be high, mostly 4 or 5, not more than that.
Sir, anything to add, sir? Gurva sir, Arun sir?
There is a question. Any change of the tibial slope from Rajiv Kulkarni? Any alteration in recreating the tibial slope?
We can increase the tibial slope from the routine 3
Very rarely needed, sir.
Tibial slope is more, it will increase your flexion gap.
We are playing with distal femoral, I think. That's what, it's wear off.
The answer to his question is no need to alter the tibial slope, right?
Yes, sir.
Yeah, okay, good. Yeah.
With our experience in...
Gurva?
Yeah, sir.
Can I ask Arun, because what Ranawat described at a couple of years back, keep this knee slightly on the tighter side because there's a posterior incompetent capsule. So in the later years, couple of years, they start extending, they start having the, again, ligament laxity. So just ask Arun whether he still follows that principle of keeping the knee brace in the night and walking for some time, maybe 6 to 8 weeks, to get a little bit of fibrosis, whatever it can go do. I still don't know. Because these people will land into recovery again and again. And there's a problem with the post and post fractures are very high with these patients.
Yes, so you have to be very careful about how much you flex your femoral component and how much you extend your tibial component, because these are then going to impinge. If you have both, if you extend the tibial components, you have to guard against keeping it parallel, keeping it at 0 degrees. So make sure you do flex the tibial component a little bit. Do not reduce the tibial slope, but do not overflex the femoral component. Otherwise, if you're using a post cam design, you will have impingement of the post. That's one point. Secondly, use some method to be sure that you're keeping the knee in flexion. We navigate, so we keep it in about 3 to 5 degrees of flexion. Keep a pillow under the knee for at least 2 to 3 weeks. Do not encourage them to do static quadriceps. Just tell them to do active SLR and strengthen the quads, but not extend the knee so that the capsule doesn't stretch out, as Dr. Pachure has rightly pointed out. So keep them slightly flexed even afterwards, during and after surgery, because they might stretch. Do not bring them to neutral. They will 100% go into hyperextension.
I fully agree. The capsule stretch is one other important factor in recurvative knees, which do not have the answer till today. Yeah, Ravi, go ahead.
Nothing. We went with primary implants with minimal DFC, minimal tibia cut, and we're able to manage. This was the post-op extension. She's doing well, sir, right now. So I will end the panel, sir. Thank you, Sharan sir, for giving the opportunity, and ISHKS, Gurva sir, Arun sir. Thank you very much. Thank you all the panelists.
Great. Well done, both Ravi Kumar and all the panelists. Great cases and a lot of learnings from there.
Yes.
We now move on to some technology.
Thank you, sir.
It's my pleasure to invite Tawfiq Panjwani, who is now going to talk about sensors and wearables. He's traveled all over the world, gaining experience in arthroplasty. He also briefly worked with us in Mumbai. So it's a pleasure to invite him to tell us about sensors and wearables in total knees.
So good evening, everyone. A very warm greetings from Ahmedabad. We are missing the warmth of the in-person meetings, but I'm sure everyone's having a good time in this virtual ISHKS meeting on a Friday evening. So without further ado, let's begin. These are my disclosures. So let's begin by saying that the world that we live in is changing at a rapid pace. And currently there are about 12 billion connected IoT devices globally. The next 5 years, it is estimated that there will be 27 billion connected IoT devices, which means one device for every 3 person living on the face of the earth. I'm sure in the audience now, about 100% of the people will have at least 2 connected devices. One will be their smartphone, and the other will be either a laptop or a tablet. And at least 50% will have either a smartwatch or an Apple Watch, which will be connected as a wearable. So the world is changing, and it's changing fast. And with that, our patient population is also changing. The ECG is now on demand on an Apple Watch. Now the glucose monitoring, which was earlier done once in a month, once in 3 months, is now, with the help of a dermal implanted sensor, is now continuous glucose monitoring. So the patients are changing, and the expectation of the patients also changing. And so also for the orthopedic community, and especially the arthroplasty community. Within the last 3 years or so, we've been scratching the surface in terms of wearables and using wearables in total knee arthroplasty rehabilitation. And mainly it is used for remote patient monitoring and assessing the rehab and the recovery of the patient remotely. So this is a study which was published in Journal of Arthroplasty, a pilot study of 25 patients in which a smart knee sleeve with sensors was given to the patients and was paired with a smartphone. And pre-op as well as post-op mobility assessment was done with the help of that sensor. So, but the most important aspect of the study was that 22 out of 25 patients found that the remote patient monitoring system was motivating and helped in better patient engagement post-surgery. In the same year, BJJ published an article in which they measured the activity profile of the patient and compared pre-op activity profile of the patient with the 6-month post-op activity profile of the patient in patients undergoing total hip arthroplasty. And in this study, they've used a wristband or a wrist smartwatch in which they could measure the steps and the activity level of the patient, as well as the sleep efficiency of the patient. So let's look at the challenges that we have in the current rehabilitation post-surgery. And the most important thing is that once the patient is out of the hospital and discharged, we actually don't know what is happening with the patient at home in real time till the time the patient comes to us for follow-up or unfortunately has to visit the ER for a certain condition. The most of this phase is the dark phase, and the patient is out of sight in the most important period of the recovery of the patient. Also, the current recovery plan is very intermittent and time-consuming because it is based on in-person physiotherapist visits to the home of the patient or the patient going to the rehab center, which involves travel and which is a costly affair. So, and also the current scoring systems are at best intermittent assessments of recovery. I mean, we will assess the patient at various intervals, but we don't know what's happening to the patient throughout that period of recovery. And also there is very minimal patient engagement and biofeedback in the current rehab systems. So we'll be looking at what is the currently available wearables in patients who have undergone total knee arthroplasty. These are the initial stages, and I'm sure within the coming years there will be improvement in sensors and improvement in the wearables. So Zimmer has come out with My Mobility app, which is in which they've paired they have paired the app with an Apple Watch. And this is an interesting paper from last year, in which they proved that this is a prospective randomized controlled trial in which the patients who have undergone formal physiotherapy, which is the standard of care, home-based physiotherapy, versus the patients who have undergone smartphone-based care management, there has been no difference in clinical outcomes as well as readmission rates. But the patients who have undergone smartphone-based treatment have, of course, needed less physiotherapy and interestingly needed fewer emergency department visits. So effectively all this is to reduce the cost of recovery as well as improve patient engagement and communication of the patient with the healthcare team. Again, for total hip arthroplasty, passively collected outcome measures, the PCOMs, were collected with the help of the same Apple Watch and the My Mobility app. Mainly step count and flight number of steps, staircase that the patient is doing was calculated, and the recovery rate of the PCOMs was similar to the previously reported recovery curves of prawns. So the interesting part here is that PCOMs may be useful augment to the PROMs to assess the patient who are undergoing recovery post arthroplasty. Interestingly, sensors can be put on the foot insoles, and the recovery of the patient with the help of the sensor data, which will analyze the biomechanics as well as the gait evaluation, which can help in augmenting and understanding the current recovery of the patient. So the study that we quoted earlier, published in Journal of Arthroplasty, uses a sensor which is developed by a company called Focus Motion Health, and it's essentially knee sensors which are attached to a knee sleeve, which is given to the patient who's recovering from surgery. All of this data is collected and then analyzed with the help of machine learning algorithms to improve the assessment and analysis of recovery. Now, TrackPatch is another knee sensor, is another company which comes with the knee sensors to assess post-op recovery and post-op rehabilitation. So in India also we are scratching the surface with development of smart knee sleeves with sensors, and which will track the patient recovery, steps, pain score, exercise compliance, knee range of motion, and basically the whole process of the whole journey of the patient from surgery to recovery. Also, remote follow-up as well as virtual rehab is possible, but this is currently in beta testing and not commercially available. So what does the future hold? So passively collected outcome measures are definitely going to augment and add to our understanding of recovery and rehabilitation post total knee arthroplasty. And the gamut of data, the extent of data which is available now, I think it will give us more and more actionable insights into the recovery of the patient post-surgery. This can help in stratification of the risk of the patient in various groups, as well as optimize the patient rehab program with the help of this massive personalized data. All of this is with a single point goal of improving the patient outcomes and also to reduce the cost. Thank you.
Great. Thank you very much, Tawfiq. Are there any questions? I think it's a very exciting development in this field, and hopefully it should lead to much greater results and improvement of outcomes with less effort, I guess. But I think there will be a little more involvement on part of doctors, isn't it? There'll be a little more work for us to do monitoring and so on.
I think it will have to be used smartly. Because we need to involve people who will be doing the monitoring for us. And I think with the way the sensors and the algorithms are working now, it will be the machines will be taking much of the load of analysis and analyzing the data for us. And with the help of that analysis, I think it will be it'll be easier for us to track the patients without actually putting in a lot of time. I agree to design the whole system. There will be a lot of involvement from orthopedic community as well as the physiotherapy and the rehab community will be needed. But as we move forward, I think it will take less of our time and will create better outcomes for our patients, hopefully. And
do you think patients will be compliant with these variables and follow up?
So there'll always be a learning curve, and I think convenience and reduction in cost are the two important things that will have to be that will be needed for the compliance of the patients to come in. So if, for example, a patient is at home and does not have to go to the physiotherapy center and is able to do the therapy and is able to do the exercises at home, that's convenient for the patient. And on top of it, if it reduces the cost also, that is that could lead to that could lead to more compliance from the patient community. But I think till the time the convenience and the cost factor is sorted, the uptake will be difficult.
Yes.
Yeah, Tafiq, good talk. But I would feel these are only monitoring. Monitoring is only part of the game. Motivation is the more important part in the post-op physiotherapy. We see time and again the red flags, the patients who refuse to move, who come into the flexion contractures with no time. So those are the guys which have to be consistently motivated or cajoled by the physiotherapist, which is lacking in these devices. The device only monitors and tells you that. And again, you have to be constantly on alert. Home.
I would like to, so I agree with the point Dr. Gaurava Reddy made, but I think what the machine is trying, or the sensors are trying to do, is tell us what the reality is, and to bring in more data for us to understand and then take corrective action. So as you said, that probably if the patient is not moving and then comes 1 month down the line with a flexion contracture, this device is going to tell us, say if the patient is not moving for 3 days, or if the movement of the patient has gone down for 3 days, it will show up as a pop-up in our dashboard saying that you need to take a look at this patient because he's not walking as much as he should, or he's not flexing his knee as much as he should at 1 month post-op. So it will the care will be much more proactive rather than reactive.
Professor of Orthopedic,
Srinand, can you mute it?
Totally others, please.
Why they mute Srinand? Yeah, okay, that's fine. Okay, Arun. Yeah.
One thing you didn't mention, Taufik, and I was hoping you'd cover that, are actual sensors being used now, like smart implants and smart inserts, so that you can get pressure readings from within the joint as well. But you didn't cover that, so we'll leave that for another day. All right, so thanks so much for giving us the insight. And next, we are going to speak to get others to speak to us about whether robots are really an improvement over navigation in total knee arthroplasty, because that's the next real advance since navigation. I think patient-specific implants came and went, and I think only a few hardcore people are using it. So robots are really the next big thing. So we want to know, are they really an improvement over what we had? And the acceptance of navigation itself was limited to maybe 10% of surgeons around the world. So whether robots are going to be an improvement on that. Let's hear you, Adarsh.
Thank you, Arun sir. Thank you, Ishq, for inviting me here today, and Dr. Pachore and Dr. Gaurava Reddy and Dr. Arun Mullaji sir for inviting me to speak today. Just going to share my screen. Okay, so today I'm speaking, I'm entering the world of sci-fi, entering the matrix. So we're going to speak about, are robots really an improvement over navigation in total knee replacement? So navigation versus robotics. The first question is, what are the definitions of these two terms? So navigation is the process of activity or activity of accurately ascertaining one's position and planning and following a route. So that is the most important word here, it's planning. Robotics is an interdisciplinary field that integrates computer science and engineering. It involves design, construction, operation, and the use of robots. The goal of robotics is to design machines that can help and assist humans. So for that, you need to know the definition of a robot itself, which is a machine which is capable of carrying out a complex series of actions automatically. Again, this is the prime word here. So navigation, planning is the prime word, and in robot, it's the action of carrying out the complex series of actions automatically. So there itself in the definitions, you have the idea. So we see all these different types of robots in the real world. Like you have these suitcases which follow you. We have this pill dispenser which tells you what time you have to take what, and then you have robotic chefs. And even in sports, you have this excellent robot which you can score a basket from anywhere on the court. So this is what we look at robots outside of the medical field. In the surgical field, the other surgical fields had robots, I think, even earlier than we did in joint replacements, like the Da Vinci general surgery and the neurosurgery Neuromate, which are one of the first robots used in surgical fields. In joint replacements, we have the Stryker Mako, which I'll be talking about today. We have the Zimmer, Smith & Nephew, Merrill, DePuy. All of them have now entered the bandwagon of robotics. So just for a brief idea, robots are classified into three main categories. One is the boundary control, where you have human interaction, deactivates beyond a certain boundary, and you're able to move anywhere in the field. Example of that is the Smith & Nephew Navio. The semi-autonomous, where you still have a human interaction, but you're constrained within the haptic boundaries and it's fixed to the actual robot. Here, again, the Mako is the example. The autonomous, fully autonomous robot where there's no human interaction and it's constrained within the boundary and fixed to a robot. And for example, you have the the Merrill QVIS robot. So just a brief glimpse of these. This is a Navio. You can see it's like a handpiece where you're free to move anywhere, but you try to work within those boundaries. And the QVIS, which is a fully automated, you're not even touching the instruments and it is doing its sculpting on its own. Here, we're talking about the Mako robot, where it's semi-autonomous. You're still holding it, you're still doing the procedure, it's attached to the robot, and it's going to help you to make sure you don't exit outside those haptic boundaries. So this is the Mako, the semi-autonomous. So just a brief glimpse of the evolution of planning and orthopedic technology. Static plans, that is the proper templating that we used to do for hips and knees, goes all the way back to the 1950s. Then navigated execution came in the early 90s. Navigated freehand power tools started entering in 2000s, and robotic arm-assisted surgeries also in the 2000s. But if you actually look at the proper timeline, I'm not going to go into the detail of this. 1992 was when the first navigation came. And in the same year itself, RoboDoc came, which is a robot which is only used for total hip replacement from QS. So it is actually around the same time. But for robotics to come into knee replacement, you should take around 2000, the second half of the 2000s. So probably around 2012 when Navio came up, Smith & Nephew came up with the Navio, and Mako came even later in 2016. So definitely navigation had a head start in terms of joint replacement, knee joint replacement. So the question we're asking is robotics truly a step above navigation? That's what we need to see. So first we need to know what are the steps that the robot does, which is different from that of navigation. If you see the Mako total knee workflow, it starts with pre-op planning, then the OT setup, array placement, patient landmarks and registration, then intraoperative adjustments and bone resection, finally the trial reduction and the final bone preparation. So these four are actually different from the navigation. These are common to the navigation, but the pre-op planning, OT setup, intraop adjustments and bone resection are things which are different from the navigation in robotics. So where is robotics superior to navigation? So the Mako total knee has three main features, and all these three core features show superiority over navigation. So the enhanced planning, dynamic joint balancing, and robotic arm assisted bone prep. So let's go one by one. First, enhanced planning. So as you see, the Mako requires a CT scan, and all these films are put together to create a 3D anatomy of that particular patient. So the first thing itself, we have a lot of information just by looking at this 3D model. So in any computer-assisted surgery, you need to teach the system the anatomical bone marks like the hip center, the malleoli, and the epicondyles. You need to do bone registration, and this information can come either image-based or imageless. Image-based relies on CT scan or MRIs or fluoroscopy, and imageless relies on intraoperative inputs. The Mako which we're talking about is CT-based. So the advantages of enhanced planning is threefold in robotics. First of all, you get a 3D CT scan, which helps with the accuracy of bone registration, understanding of the pathology, the location of the osteophytes, defects, metaphyseal cysts, etc. Next, you can do the pre-planning. You can have accurate sizing of the implants before the surgery even starts, shape matching of the femur. Now we can even reproduce the posterior condylar offset, which was never possible earlier. And of course, we have the option of having well-defined haptic boundaries and big data from lakhs of CT scans. So what about the bony landmarks? One by one, if you see the advantages, in the pre-planning itself, bony landmarks in robotic, as I said, because you already have a CT scan, you just have to match the epicondyles and the malleoli and the center of the hip. But for navigation, you have to physically locate all these landmarks on the patient's anatomy, and it is prone to error, which is proven in a lot of literature. So this is some literature showing registration errors in imageless navigation systems. So various papers, these are all Journal of Arthroplasty papers, and Dr. Martin Roche's paper shows 1.4 degrees coronal mismatch, 4.3 degrees of sagittal mismatch, and 8.3 degrees of rotational mismatch when you're using imageless navigation. So what about the actual bone registration part? So as you know, we have to enter to multiple points on the bone so that the robot or the computer knows exactly where it is in real time. In robotic, the system already has the true 3D CT, so you just have to do 40 points to validate it. It has a high accuracy of less than 0.5 millimeters. But in navigation, you have to do a surface mapping of the bone, and this has definitely a less access to the posterior aspect, so definitely has less accuracy. So this is a paper by Sebastian Lustig. Of course, this is about partial knee replacements. He's compared manual partial with navio partial and Mako partial. And he has found that femoral posterior offset, tibial sizing, and femoral undersizing are much higher in the mechanical and a little higher in navio, and the Mako has almost consistent results all round. So next, in enhanced planning, you have a better understanding of the pathology, the location of osteophytes, and the bone defects. You can see the bones in all the different planes. You can see where are the osteophytes beforehand. There's a huge defect. We can decide beforehand whether you need to do anything about it or not. Again, you can also decide whether you need to put any stem extensions or augments or even bone grafts just by looking at this 3D planning. Enhanced planning again. So next thing I mentioned earlier was the shape matching of the femur. You can match the trochlear groove now just by doing some bit of a rotation. You can perfectly match the posterocondylar offset. Mediolateral fit can be decided right here in the femur as well as the tibia. Of course, the sagittal planning also is possible now. You can determine what is the slope of your implants, what you want to put your flexion extension of your femoral implant as well. And this is only possible with image-based robotics. So as I mentioned earlier, you can move your implants in 6 degrees of freedom. So femur and tibia in all the 3 different planes can be moved in varus, external rotation, and flexion. And you have so much of things that you can play around with. So you may ask, what are the disadvantages of image-based planning, like CT scan? The first thing everybody is going to say is a lot of radiation. So if you know a CT chest has around 7 MSVs of radiation, but this paper showed that the superimposition of the femoral and tibial axial images for our Mako CT scan is less than even 3 MSVs. So it's really not much of radiation at all. So let's go on to the next part of advantages, the dynamic joint balancing. So as I mentioned earlier, you can take real-time balancing of the joints, see what are the tautness of your ligaments on the full valgus and varus stress, and you can play around with your implants depending on this. So if you see over here, in extension, when I've given valgus and varus stresses, we got these numbers, 20 millimeters and 70 millimeters. And in flexion, again, after giving the varus and valgus, we got 19 and 16. So there's a lot of mismatch. The aim of all these surgeries is to bring all these down to equal, usually 19 gaps. All we need to do is titrate the position of the implants. You can choose whether you want to go for mechanical alignment or a functional alignment versus kinematic alignment. We had a lovely talk about kinematic and non-mechanical alignment. So if you take this example, initially on extension, we had 20 millimeters lateral side and 17 millimeters on the medial side after giving full valgus and varus stress. And on flexions, we had 19 and 16. So these are completely mismatched gaps. So what you want to do, first I pin the tibia laterally and I give a 1 degree varus on the tibia. This helps to open up my medial side on extensions. Now I become 20, 18, 19, 18. Next, I anchor my tibia medially and then I give another degree of varus. By doing this, I've closed up my extension laterally. So now I become 19, 18, 19, 18. Now what I want to do, I change it on the femur, anchor laterally on the femur, and then give another degree of varus on the femur. So now combined varus is 1 plus 2, it's only 3 degrees. By doing this, I got 19, 19 on extension and 19, 18 on flexion. So I still have 1 millimeter tight on the medial inflection. So what I do, I flex the knee, anchor laterally, and just give 1 degree of external rotation. I have a perfectly balanced gaps. And just by doing this small amount of titration, I managed to bring 20, 17, 19, 16 to 19, 19, 19, 19. And if you go for navigation, for example, the brain lab knee, each cutting block has to be physically placed by the surgeon in the position that he desires. And the challenge is to achieve optimum position 3-dimensionally. Manual saw is again used to make the cuts, and only after the cuts are made do we know whether we've actually matched our plan or not. And it depends on the dexterity and the experience of the surgeon. So you may not get 100% reproducibility if you have varying surgeons. Just to summarize, the joint balancing, it's not influenced by the experience of the surgeon, but in navigation, it is depending on the surgeon's dexterity. So next, the third advantage is the robotic arm-assisted bone preparation. So this is the main thing where you're actually executing your plan, which you cannot do with the navigation. So as you can see here, you have the haptic boundaries, and the robot is attached to your saw, and it helps to make sure that you do not exit outside your boundaries. You can go in and cut your bones safely without cutting extra bone, without cutting your ligaments. I'll just show you this clip. If you can see here, we're going physically, making sure that you're not going outside your boundaries. You can just look at the screen and make your cuts. You don't even have to look at the field. So the robotic arm has haptic feedback, the tactile feedback, resisting surgeon from moving out of the haptic field. You also have auditory and visual feedback. And if the knee moves with the robot, the robotic arm also moves along with it. So you have sub-millimeter cut precision, and soft tissues are definitely saved. Other reasons why robots are superior, of course, we can do the unicondylar also for AMOA, and you can also do other ACL preserving surgeries like medial, lateral, patellofemoral arthritis, bicompartmental surgeries as well. THR is also possible, and uncemented knee precise cuts helps to make uncemented knees amenable. So as I mentioned, you can do all the different types of partial knee replacements with the Mako. You can do total hip replacement, you can do the 3D cup planning, 3D stem planning, and you can even check the limb length discrepancies as well. So let's look at the literature. Robotic TKRs, these papers have shown reduced post-op pain scores, reduced post-op analgesia, better range of motion, less number of physiotherapy sessions, and early time to discharge. Other papers, in this paper by Faris Haddad shows the MAST score and a reduced bone and periarticular soft tissue injury, because we are hardly doing any soft tissue release now, thanks to the little bit of titration of the implants that we can do. So if you talk about some more literature in robotic here, better WOMAC scores and reduced pain scores. But what about TKR versus CAS? There is one paper here, which is done in 2018, shows less operating time, better alignment, and less hospitalization in robotic TKR versus CAS. What about navigation versus conventional? Is it showing much of advantage of navigation versus conventional? Not really. Most of these papers show there's not much difference in the clinical outcomes and survivorship when you're using navigation versus conventional. So if you want to summarize, these are the olden days. I remember in my childhood days when Dad used to drive us down the motorway in England, he used to have this huge map out in front of him, and he used to be like wondering where to go. Are we going on the right motorway, left, right? There's no clue where we're going. This is manual. Okay, if you're looking at an X-ray, it's like looking at an old physical map book. Then we got the Google Maps. This is like, I would say this is navigation. It gives you an idea that, listen, if I want to get from Hyderabad all the way to Mumbai, this is probably the best route to take. And it gives you even like the amount of time that you need to take. It's only going to help you plan. It won't help you go exactly there. And then now with semi-automated robots, it's going to tell you, go straight, take a right. There's probably going to be some traffic over here. Avoid this, go straight again. You don't want to go under the bridge, probably go above the bridge. It's going to give you these particular instructions and going to help you go according. It still makes you drive, but it gives you all this information beforehand. And if you want to go for fully automated robots, you have these sensor cars, driverless cars. It's going to sense where are the cars all around, is there any pedestrians around, and it'll take you there directly. So there's a huge jump from these old days with the map to the driverless cars. So that's where I feel the difference between navigation and robotics in joint replacement surgery. Thank you so much.
Great. Thank you very much, Adarsh. That was a very convincing talk that there are certain features in robots which are clearly an advantage over navigation. And I think if there are no, I think in the interest of time, can we move ahead, Guruva? Because we have...
one or two questions from my side, Arun.
That's not allowed. You can ask him at home or dinner.
I'll ask you.
He wanted to ask you.
I'm asking you. Arun is a great proponent of navigation. You and Rajesh put the navigation in the map. And what is holding you back to go to the next step, robotics?
We don't have the sort of money that you have, Guru.
Okay, I got it. Okay. Publicly, we will exchange our properties tomorrow. Okay.
Send over one. Send over a robot.
Okay.
All right.
Thank you, sir. Thank you for the opportunity.
Okay, great. So can I invite Dr. Aditya Dastari, who's been waiting very patiently in the wings, to to talk to us about imaging of the painful knee arthroplasty. We somehow missed out the arthroplasty bit. So it's not just in general knees, but the replaced knees.
Okay, I need to be allowed to share my screen. I know radiologists are not allowed everywhere, and this would be another such place, but I can't actually share my screen.
Aditya needs no introduction. He's a great radiologist from Mumbai, and he's got a tremendous interest in orthopedics. So look forward to listening to your talk, Aditya.
Hi, thank you so much for the kind introduction. As you know, I'm a radiologist. I live in the dark. I'm here to try and shed some light on what I do. And also, I just wanted to let you know, you all know what radiology is. We're like Instagram for doctors, just sort of like, share, do that kind of stuff. But today my talk is titled Post-Knee Arthroplasty Pain. And what I'm going to do is I hope my whole screen is seen and it's not covered by any of the other stuff that's in the background, because some of the things are in the corners of the slide. So what I'm going to do today is I'm going to just limit the talk a little bit in the interest of time. So I'm not going to go on X-rays, because I think you see many more X-rays than most people do. CT and PET I'm going to just stay a little bit away from, but I am going to focus primarily on MR. Now, whenever we see a painful arthroplasty, my approach to looking at the MR is focused on the bone, looking at the bone cement prosthesis interface, looking for fractures and bone edema. I focus my energies a lot on the synovium and trying to understand the synovium, because that's often a cause for pain, and also in terms of determining whether there's infectious inflammation or other conditions. We look carefully at the soft tissue restraints, both medially, laterally, as well as in the extensor mechanism. The neurovascular structures. Alignment is on imaging still a controversial area, but we do look at it at times just to sort of give us an idea. And then finally to look a little bit at the liner. And this is again better seen on radiographs and CT than on MR. Okay. So I think one of the important things that everybody asks is, can you put a post-plasty knee in the MR scanner? I think members of this audience would know this by now, that you absolutely can, and you can put them very quickly, even the day after surgery. We get great images with this, and I think after a radiograph, this is probably the #1 test of choice when trying to evaluate post-arthroplasty pain. There are certain factors that affect the artifacts that come with an MR. The first thing is the actual component construct. So cobalt chrome produces more artifacts than titanium or zirconium. The sphericity or the geometry of the structure. So more spherical structures will tend to produce more artifact than straighter structures. So for example, a hip or a shoulder will have many more artifacts than a linear femoral shaft nail. The distance from the center of the field of view. So the shoulder or the hip, it's very difficult to bring it to the center of the MRI scanner, whereas the knee can be easily brought to the center of the MRI scanner. So it's a pretty good place to image. Orientation of the axis of the implant, whether it's against or along the field of the magnetic field. So knees are pretty good with that. And the artifacts are greater with the 3 Tesla scanners as opposed to the 1.5 Tesla scanners. But that being said, we currently image most of our patients on a 3 Tesla scanner. Okay. So anytime I'm reading an arthroplasty study, there is a very, very important question I ask. It's probably the most important question before you read the study. Primarily it's, are you the primary surgeon? Because once you know that you got a case from the primary surgeon, then you have to really, really be very diplomatic on how you interpret it. But that being said, we are sort of very concerned about what we report. And we do realize that there's a lot of variability and there are a lot of challenges to reporting. There's a lot of difficulties. It's very, very important in these situations, especially to have a good sense of the clinical picture that you're dealing with, and also to get all the correlative imaging. So I will seldom read an MR of a post-plasty knee without the radiographs or any other imaging that has been done. So MR, just to give you a sense, we're really, really good at looking at the bone prosthesis interface today. You can see here on this image that you can see the normal bone prosthesis interface here. I hope you can see my arrow. If not, then I'll have to just see how I can bring that up. But here you can see
Yeah, it's visible.
It's visible, right? So here you can see very clearly that there is nothing between the cement over here and the bone underlying. It looks very clean. There's no problem with that interface. And here you can see very clearly in a patient who's got poor osteointegration, you can see a clear interface between the prosthesis and the bone, essentially telling you that there is no osteointegration along the entire tibial stem, and this would probably be loose. When we see osteolysis, you can see larger sort of lytic areas along the osteolysis, and you can see this quite clearly on MR as well. Now, obviously, anytime we see osteolysis, the next thing you're concerned about is how big and what is the extent of osteolysis and involvement. And here's an example of somebody with osteolysis where you can see it scallops the cortex, and somebody's actually developing a stress fracture here. And here you can see somebody also with the same patient with another look. So you can see thickening of the cortex very nicely. And you can see this is primarily because of a little bit of subsidence and probably some migration of the stem and increased stress loading along this cortex. Whenever we see osteolysis, obviously the next question that one tends to ask is there infection or not? And here I find MR is great at showing you the entire extent of osteolysis or poor osteointegration, the actually morphological features, if it is smooth or if it is irregular. And then what we often look for in cases of infection is to see tracking of that osteolysis and soft tissue down into forming sort of this tract outside and a sinus tract, such as you would see here tracking out, which is again something that tends to push one more towards infection than this being simple osteolysis. Another thing that helps us a lot is to look at the synovium itself. So when you see this sort of thick, shaggy, irregular synovium, that is a more aggressive appearing synovium. And then that again guides us to being more towards dealing with a situation of infection over particle disease or something else. And I'm just going to show you this example, which is a different one recently, where you can clearly see the osteolysis along the tibial stem here. You can see a large area of osteolysis here on the femoral stem, on the femoral shaft. And here you can see, in fact, that on this non-fat suppressed image, this area of osteolysis is rather difficult to demonstrate, or maybe hard if you haven't seen these often. But on the fat suppressed images, it's very clearly visualized. And on the other hand, sometimes the tibial sided changes may be harder to see on the fat suppressed and easier to see on the non-fat suppressed images. So it's important to look at both images. It's important to look at all the structures in all three planes because these can be quite tricky. And then in this case, you have these large areas of osteolysis, and it's very clear when you look at this synovium, you can actually see the particulate debris within the synovium. And you know this is all from polyethylene liner wear. So you know this is not a case of infection, but this is polywear dealing with this. And this also ended up being a patient who was considerably post arthroplasty. This wasn't a recent arthroplasty. So again, more likelihood of this being just plain old polywear and related osteolysis. Looking at the liner itself can be quite challenging on MR because of the artifacts. CT is also decent to look at them, but can be difficult, but it's very hard to beat a plain old X-ray. And you can see here how there is just, rather than just the thinning of this, you can see how there's irregularity of this entire poly posteriorly, and we know there's actually poly wear here. And again, while this could be some amount of narrowing, you can see how the anterior polyethylene has got a really nice smooth margin, whereas the posterior polyethylene is quite worn out and irregular. So again, this is sort of an example of where we can see liner wear better on radiographs than on MR. Assessing the synovium is rather important for us when we're looking at these. And here you can see an example of somebody with smooth synovium with a little bit of nodularity, which I would term as more reactive. Here is again smooth, just thick-walled synovium, which we would term again as reactive. Here is where you have sort of more nodular appearance to that synovium and debris, which is more of particulate debris, and this would be a particulate synovitis. And then here is somebody who's got a very thick, shaggy, heterogeneous appearance. So you see this is very homogeneous, this is rather heterogeneous, and that's more of an appearance of an infectious or a very aggressive inflammatory synovitis. When we're looking at the synovium, there's some other things you can see. So here's a patient who had a unicompartmental arthroplasty. And here you can see the cystic change is not typical for a geode. In fact, it's got a broad base. The geode tends to have a narrower base at the subchondral bone. And when you look at this a little bit more, you can see there's a fair amount of bone marrow edema around that geode. And you look at the synovium, it's kind of thickened and heterogeneous. And this actually ended up being a uni that was done on a patient with rheumatoid arthritis. And this was reactivation of the rheumatoid arthritis. Suprapatellar clunks are something that we often get referred cases for. You can see the suprapatellar synovium quite nicely over here. You can see thickening of the suprapatellar synovium, which is fairly typical for patients with a clunk. And then we can also see areas where we have more diffuse synovial thickening, which is fairly rigid without an effusion in patients who have arthrofibrosis. We do have patients who occasionally present with recurrent hemarthroses, and in these cases, we've been able to do MR angiograms. And on MR angiogram here, you can see that the superolateral geniculate area has got increased vascularity as compared to any of the other vessels. And it's usually a small little vascular tangle in that area that is causing this. And oftentimes these recurrent hemarthroses can be treated by an interventional radiologist by doing thromboembolization of those vessels. Now, recently, there's been some papers about actually treating even OA-related pain with vascular thromboembolism, but I think that's a bit controversial still. We get a good look at the soft tissue restraints, especially when you have unicompartmental arthroplasties and you're trying to look at the opposite side, then you don't have the issue of artifact, and you can see the soft tissue restraints quite nicely. So this is a popliteus tendon rupture. You can see the extensor mechanism very, very nicely, and you can see discontinuity here of the extensor mechanism superior to the quad tendon rupture. You can see that there's not much of a stump left. You can see that there's inferior migration of the patella itself, and you can see the buckled quadriceps tendon up here. On the axial image, you know that the tear is actually extended to involve the medial patellofemoral retinaculum, and you can see an abnormal tilt to the patella and discontinuity or absence of the medial patellofemoral retinaculum and medial patellofemoral ligament. Here is an example of the medial aspect of the joint. You can see the tibial attachment of the medial collateral ligament, and then you can see the femoral attachment has completely stripped off the femur. So again, a case where you have medial soft tissue restraint failure. Here's another example where you actually see the femoral attachment is intact, and you can see the tibial attachment is stripped off completely. Now, having said this, I know that there would be procedures that are done where you would do a medial release, and these can look like that. So the important thing to remember is the patient actually having an element of medial instability? And again, this is why it's important to speak to the surgeon whenever you're doing this, irrespective of who's done the surgery, because you know that many things are simply post-operative changes that are not necessarily symptomatic. Looking at the neurovascular structures is another thing that we can do quite well. So here you can see the peroneal nerve here, and this is from the literature. And here you can see a nice example of somebody with a peroneal neuroma, which can also be a cause of symptoms. I mentioned the issue of axial alignment, and I think all of you know this a lot more than I probably do. We can give you measurements of alignments. There is a lot of variability in the techniques used for alignments. There's a lot of variability in terms of what people consider appropriate and inappropriate. And so in general, while we can give you these numbers, I think these are things that need to be just treated with a little bit of skepticism when they come across. And so it's better to just discuss these out with the referring physician rather than document them in text without their knowing, because then patients run around with numbers, put them onto Google, and then that becomes a whole new kettle of fish for everyone to deal with. So what I've tried to do rather briefly, and try to leave some time for questions because I'm sure there might be, is our general approach to looking at MRs for post-arthroplasty pain. I think these are some of the studies that are very, very helpful past following a radiograph. It's important in these situations for there to be a clinical correlate to when you interpret these. We can give you great information about the bone cement prosthesis interface, as well as fractures and stress reactions. We have a really nice understanding of synovium and looking at it for infection, inflammation, and at least while we can't be necessarily 100% diagnostic on infection versus non-infectious disease, we can give you significant clues that take you one way or the other. We get a pretty decent look at the soft tissue structures, the neurovascular structures. We can give you some sense of the alignments, and we have ways to look at the liner as well. And I think, again, the key thing driving issues for looking at this is it's important for us to understand where you are looking for pain or what the patient's pain symptoms are. It's important for us to look at all the imaging that is available in order to give you a good idea of where the pain might be coming from. So with that, I'll stop and take any questions if there are any. Thank you.
Great, Aditya. That was super. I think it's really made us very much more aware of how much information MRIs can give us when we're dealing with somebody with a painful total knee or a painful uni. Any questions?
Arun, can I?
Yeah, of course.
Yeah, Dastari, Aditya, thank you for joining us in the ISHK. Can I ask you something? Because we learned from USG and CT and MR both infection, the compartment usually get violated. That is the way we actually has been a pathognomonic sign that what they described was even on a CT, if your compartment is broken, there you are looking for infection. Is it true on the MR?
When you mean by compartment is broken, can you clarify what you mean by that?
Suppose there is a hip, the whole the soft tissue has gone into adductor compartment, or any other compartment. The knee, something similar way, it has broken the whole synovium and it extended into the compartment, either medial or lateral compartment.
So you mean that when there's an extra-articular extension of disease?
Yes.
I don't buy that anymore. I think that we have cases where we have osteolysis, where we have large amounts of particulate synovitis that can violate the compartments. But that being said, I think when you have a compartment violation that occurs very early post-operatively, then you are obviously more concerned about infection. Whereas if you have a compartmental violation and you have a patient who has insidious disease that has been progressing over a period of time, then you start to think that, is this sort of infectious or non-infectious? So if I go back to thinking about sort of the bone tumor analogy, we talk about things as being aggressive or non-aggressive, and then you sort of decide on, the infectious or non-infectious component. So we've seen many cases where synovium looks very aggressively inflamed and you have elements of membrane formation and nothing, but when you actually aspirate the joint or you look for infection, nothing actually grows. So there is some sort of aggressive, reactive, inflammatory process that goes on that we see, which is an aseptic process. So long answer short, just because something is breaking out of a compartment, I'm not inclined to just say infection. I would do exactly what I said before. I would ask you, what is the story? How quickly has this been happening? What has been happening? Where is the situation? And then I would take a call on where we're at. And I'd also look at the morphologic features of the structures to say, if this all looks particulate, then obviously I'm more inclined to say particulate.
Can you just a little enlighten on alveolar lesions on this MR?
They tend to be, again, more sort of osteolytic lesions when we look at them, and also sort of thickened synovium is what we would generally end up seeing. They're probably more in the hip than in the knee.
Yeah, I agree. Right. Because they are more destructive, and there is actually a lot of muscle destruction which takes place with alveolar lesion,
right,
rather than just an osteolysis. That is what our experience is.
Yes, they're definitely more, and that's exactly what it's coming to. There are certain, osteolysis, in my opinion, is sort of a reactive process to something that is, by the arthroplasty components is irritating. And it can irritate to a variety of degrees. So in some situations, you can get a rather aggressive irritative process in which you get large osteolysis that looks very aggressive, that extends into the adjacent structures, which you would see in something like alveol. Whereas on the other hand, you can have something that's more insidious and slower growing that produces osteolysis, and that just creates synovitis that just sort of continues to grow slowly within the joint rather than giving a more aggressive appearance.
Thank you.
Great. Thank you so much, Aditya, and sorry that we kept you a little long.
Not at all. My pleasure. Thank you.
Great. So now we'll just change the order a little bit, and we'll request Dr. Vaibhav Bagadia to give his talk, so that then I see that we have Dr. Jawad Parvezi who has joined us. So he will be okay with his time as the next speaker. So over to you, Vaibhav. Yet another young, bright star on the horizon. And he's going to tell us about AI and ML in arthroplasty. Vaibhav, are you there?
Hi. Yes. Thank you. Am I audible and visible?
You are, both.
Yeah. So thank you, Dr. Mullaji, for giving me this opportunity. Now, this is seemingly a boring and theoretical talk, and we are in the glamorous ISHK. So it's very appropriate that I start on a very philosophical note here. And this is one of my favorite things. And I think as we will realize that slowly, we will realize that everything that we do or everything that we are created is a part of a master algorithm. And the God itself is a programmer or a programming language. It's very philosophical, but more and more that if you dwell into the science, more you dwell into the algorithms, we'll all realize. And that's what we are. Everything that we do today, everything we are now touching. And once what we consider a subject of fiction is now invading and changing every part of our life. If we think about the suggestions that we receive from Amazon, Netflix, flight bookings, Google, it almost seems to read our mind. And behind all this is an algorithm. Now, AI and orthopedics. Now, arthroplasty holds a special place. We are always an arthroplasty surgeons equipped to adapt, refine, and integrate technology in our practices. And we had some very eloquent talk by a lot of people talking about technology from wearable sensors to robots. And I think that's where we are. And we have seen the exponential growth because of this attitude. And we'll be seeing and we'll keep seeing the integration of navigation, robotic, and 3D imaging in orthopedics. In today's talk, I'll keep it simple. Because I know it's such a vast topic and we can have the entire day conferences on these. We'll talk about understanding three key things that I feel are necessary for us to understand, which is artificial intelligence, machine learning, and deep learning. And we'll also talk about what is the potential likelihood of transformation in arthroplasty field with these. Now, concept of AI is very generic. It involves machines that can perform the tasks that are typically a characteristic of human intelligence. For example, any planning, understanding languages, recognizing faces and sounds are, if the machine is able to do any of this, it's called as artificial intelligence. But the core of it is if it can solve problem like what humans do, it's where the artificial intelligence stands. And at the heart of all this is algorithm. Now, algorithm is the building block of any of the AI project. It is a set of instructions that is given to computer in form of sequence, which would lead to a desired output. Task can be very simple or could be complex. And it depends on how we want to structure the whole thing that the algorithm takes place. Machine learning often used synonymously with this is basically an algorithm where we train an algorithm how to perform a task. It could be inductive or deductive, and it could be supervised, semi-supervised, or unsupervised. So if you look at different eras, we started with reactive machines, where we would give a direction and it would be performed. Then there came machines which had limited memories. Then machines with the theory of mind, and eventually we believe that we'll reach an era where we'll have self-aware machines. In orthopedics, of course, there have been different things, and the primary thing that has happened, or the lowest hanging fruit in all of this, is the orthopedic imaging. We heard talk by Aditya, but many of this with the use of AI will become much easier. And we have ourselves, these are different publications that we have in last few years on use of AI to predict many things. In our own thing, we published this article in Arthroplasty, and then this about how AI can predict osteoarthritis. And our assessment of this thing had a very high precision. And I think that's where we are moving. What Aditya explained to us, there will be very few Aditya-like people in the whole country. But with AI, we'll have things that will tell us whether it was infection, whether it is just a simple osteolysis. And I think with increasingly sophisticated algorithms, we'll be able to do a lot of things in arthroplasty with certainty. In fact, so much so that this is a very interesting study that we just have submitted, in which we used AI to identify implants, a very common task that we performed in our day-to-day life. And there were some of the algorithms which achieved 99.6% accuracy. And to our surprise, they were actually better than humans. My fellow had a 77% accuracy, and I had an 86% accuracy compared to 99.6% accuracy that these algorithms had. So I think in these two spheres, at least, we'll see results in next couple of years, not even decades. Now, deep learning is where the sweet spot lies, and I think that's where the arthroplasty will be completely transformational. And I think it is more to do with what surgeon thinks and how the machines will integrate with humans. It's sort of inspired by structure and function of brain, which means interconnections. So deep learning moves from machine learning to an era where there are a lot of interconnection happening about the learning and also about how humans interact with machine. And I think there we have heard a lot of talk about alignment and balancing. And I think with AI, the term that we should use in this era is intelligent alignment. And with robotic, I think this paradigm has shifted. The key is the surgeon and artificial intelligence in action. Now, how I do it and how I see it is that we set certain non-negotiable terms with machines, and then we negotiate with machine to win-win. And I'll just give you an example how the AI happens in a robotic setup. We have all had different philosophies. We are all married and tied, and we have changed our marriages and changed our girlfriends. But if you see, we started from 1970s, and today in 2020s, we have moved from mechanical alignment, anatomical alignment, kinematic alignment to this era of intelligent alignment. And how do AI help in this? Is that as a surgeon, I have set certain non-negotiable terms. For example, we have seen how Adarsh changed his alignment philosophy. So for me, it is maximum 5-degree varus, preferably less than 3-degree varus, combined varus in the femur and the tibia, and 2-degree valgus. Balance is something that I want to be absolutely good, which is 2 millimeter medial lateral balance, and gaps equal or slightly loose in extension, slightly loose in flexion for UKS. I do not want any notching. I don't want any overhangs on both the femoral and tibial side. And as far as possible, I want a joint line preservation. So these are the set of non-negotiable things that I had given my computer that, okay, like this is what I want, and I would not negotiate. Earlier, it used to give me a lot of combinations, but then it used to negotiate, and then the machine and I negotiate on certain things, which is femur positioning in AP, rotations up to 5 degrees. As I said, varus valgus up to 3-degree varus in individual component and 2-degree valgus in the other things, and tibial slope up to 5 degree, and a change in implant sizing. And there the tango begins. So this is the artificial intelligence and human in action, pretty much like navigation, but here the advantage is the machine learns, and because all the data is transmitted over time, the machine refines itself. So you'll see this is what I am doing, but this is also the machine learning algorithm that are running in background. I'm changing the gaps, I'm changing the rotations, and all this thing is being powered by an algorithm which is in back, which understand what surgeons wants. So as I said, it understands what makes me the happiest, what makes me okay, and what makes me angry. So if you look at this, I would want 4 things: alignment, balance, component, releases. With AI and human in action, I can be the happiest. And that's what I've realized over time. And it has also helped us define the bullseye. This is what we start. We want a good balanced, we want a good aligned knee, but it is different for different people. We were happier when we were in this era. We were happiest when we were in this era. But defining the bullseye in arthroplasty is where the AI and ML or machine learning will make the most impact. And trust me, friend, this bullseye will keep changing because AI will give us the data to understand where the right alignment, where the right balancing, and where the right component positioning for the patient is. And as I said, picture abhi baki hai. There is a lot of hype, there is a lot of hope. I think we moved even in the era of robotic from trough of disillusionment, then the enlightenment, and finally I think we are entering the decade of productivity where we'll see more robots, more AIs, more MLs, more deep learning embedded in our lives. It is the AI I say is what AI and robotics both, I think in arthroplasty is like what internet was in 1987. Time is now, and I think the future is ours to create. Thank you, everyone.
Thank you very much, Vaibhav, for giving us a little insight into AI and ML. Are there any questions anyone would like to pose? Yes, Guru.
Yeah, Vaibhav, I fully agree with you. I'm sure all the other surgeons will agree. We are just scratching the surface of the technology. With machine learning and the big data, in the next decade, there will be a fixed algorithm to tell the knee replacement beforehand. You cut the medial collateral ligament up to this, you go to here like that. A complete algorithm will be available beforehand before entering the theater. You just execute that plan. And that is always, I'm almost coming, I can see that. And that is the real advantage of the robotics, especially in Indian scenario with complex deformities.
I agree, sir. A very interesting question, Vaibhav. I think that was more an observation by Guruva. But there's a question for you, which is a very interesting question posed by Murali, and there are two parts to it. One is about the demographic bias. Now, all these algorithms which you're quoting in your computer is by this multinational company, which is probably using Western data. And we are applying those algorithms based on Western patients to our Indian patients. So how applicable is that? And secondly, how do you tackle the potential medico-legal aspects of using these algorithms which may be incorrect or which may lead you astray? Two separate questions.
So to the first part, I think that's what technology does. It makes the world flat and it makes you individual at the same time. So the big data, what it does is that it makes it surgeon specific and patient specific. So the data enables, because learning, so all the biases are eliminated. As a surgeon, we are biased and married to certain philosophy. As a patient, we assume that an Indian patient would be shorter in height, will have BMI of something. But I think that's where big data comes. And because the amount of data surpasses the experience that a surgeon had accumulated in years, I think our biases will be eliminated with AI and the world will be truly flat. To the question that the algorithms currently are based on the Western data, I think it's an evolving phenomena. The more we do, the more data is being sent across and more data is being analyzed. So as more and more things, we are already at tipping point where the data are incorporated. And in fact, I think the most progress has been made in last 3 years of incorporating Indian data.
Yeah, so I think you're right. NACO is created a separate cell for Asian data, and we are one of the largest contributors to that. Yeah, so the Indian data is also there in coming to the picture.
Yes, so world has become flat and small and personalized at the same time. To the second part of the question, I think this is a very large issue that is plaguing about the medico-legal or any other impacts. If you look at the Tesla self-driving cars, there was an issue we are saying that if an accident happens with a Tesla car or a self-driving car, who would be liable? Whether it would be company, whether it would be the owner, whether it would be state, whether it would be regulatory authorities. I think it's a very complex issue, but at the moment, it's the decision maker who is liable. We'll still remain till the time we remain the decision makers. The day the decision is handed over to the machine, I think we'll not be liable. So I think in all things that we do, we know that the key is decision making. And I hope and wish that it still remains with surgeon. And so will liability.
Great. That was a great talk, Vaibhav. And now it's my great pleasure to invite Dr. Jawad Parvizi, who, of course, needs no introduction. He's famous on all the planets around as well. He's in Philadelphia, and he's known for his work in PJI as well as in DVT and embolism following arthroplasty. So without any delay, I'm grateful to him. He's traveling and he's enjoying Italy at the moment and having some lovely wine, I believe, out there. So he's in the right frame of mind to tell us about one stage exchange for infected total knees. Jawad, thank you very much.
Jawad,
thank you so much.
It has been a privilege to have you here.
Thank you so much, Gaurav. Thank you, Arun. Can you hear me? Because I'm talking through the earphones. Is it okay? Right. Perfect. And apologies for the little noise in the background. I miss you, my friends. And I am honored and delighted to be part of your meeting. I hope we'll be able to do this in person very soon, as I promise my family to bring them to India very soon. Thank you again for your very kind introduction. I hope so. I hope very well. So I've been given the task to cover one stage exchange in 10 minutes, and I will try to do so. I have no conflict of interest. We all know that there are multiple options available when dealing with infection, but the two-stage exchange being still the most preferred method for treating at least chronic periprosthetic joint infection. But in recent years, we've been seeing many series of two-stage exchanges that had reported 100% success rate. Let me tell you that that is probably not true, and the numbers are much less successful than the 100%, because some of the numbers are ignoring the fact that other issues arise as a result of two-stage exchange. When we looked at our results in our institution, the success rate or infection control rate was more about 72 to 75%. First is how you define success. And if you have a strict criteria for definition of success, then your numbers are not going to look as great. Retaining a prosthesis is very different than retaining prosthesis and putting a patient on long-term suppressive antibiotics, for example, or having a reoperation. You must look at the data critically. Aseptic loosening in most of these series happen in 5 to 10% within 5 years. You could argue these are infections that are coming back, and the culture being negative doesn't necessarily rule out infection. Second fact is that about 11% of these patients who have their first stage never get reimplanted. 7% die between reimplantation. And some of these are dying from so-called unrelated deaths. But if you have a heart attack as a result of anemia after undergoing resection arthroplasty, I would argue that is definitely related to the surgery. And then unfortunately, the mortality from two-stage exchange is pretty dismal, about 72% survivorship. Some of these series have short follow-up. The longer you follow, the worse the outcome is. And functional outcome is dismal. This is Guoli's work from University of Pennsylvania. Showed that really, if you talk to these patients, about 30 to 35% of them are unhappy. So is two-stage exchange a gold standard? No, not really. Current strategies are barbaric. And two-stage exchange has a lot of issues, including stiffness, scarring, and the social. And at the end of the day, sometimes, unfortunately, patients still lose their limbs. So the inability to eradicate TJI with the so-called gold standard treatment, in my opinion, draws into doubt the success of current surgical procedures, and we do need better options. So there has been a move towards one-stage exchange in North America, thanks for data that's coming out from outside the US. The question that we have to ask is, who are the best candidates? And how should the one-stage exchange be done? We all know its advantages. It's one surgical procedure, shorter recovery, decreased expense, shorter antibiotic administration. But most people feel that one-stage exchange may have inferior outcome. Best patients, elderly patients who are unable to tolerate multiple operations in particular, when they are infected with a favorable sensitive organism, and that has a good antibiotic profile. Are the results inferior? Not so sure. This is Clochi's work, 84 patients, follow-up about 2 years, and they use a decision tree. So very important, because this was a select group of people that was undergoing one-stage exchange. And in their series, they found that out of 38 one-stage exchange patients, there was no failures. 3 out of the 46 in the two-stage exchange failed. And they failed with a different organism at a later date. And another study here that shows, again, looking at the publications related to one-stage versus two-stage, the outcome wasn't so different. Now, granted, there wasn't that many papers published on one-stage exchange at the time when that review was done. Another review was done recently, and again, they're looking at all the publications related to one-stage versus two-stage. Reinfection rate was slightly higher in the two-stage exchange, but there really wasn't that much of a difference between the one-stage versus the two-stage. This is Jean-Noël Argenson's work, 47 patients, and they found that the infection control rate between the one-stage and the two-stage was fairly favorable. But again, some of these were hand-selected, and some may argue that they were better patients in terms of host grading system. This is Heinz Winkler's work. He's written a lot on one-stage exchanges. He usually uses allograft that's impregnated in vancomycin. 92% infection-free in his series. That's pretty good numbers. Markov's analyses showing that obviously looking at the quality of life adjusted years, the outcome for one-stage exchange appears to be better, which makes sense because one operation's less burden on the patients. But that Markov's analysis and others have called into question the quality of data that exists right now, and they have asked for a randomized prospective study. Well, help is on its way. Steve Jones from United Kingdom is conducting a randomized prospective study, and Tom Ferring from the US is conducting a randomized prospective study. And Tom Ferring has done an amazing job, and I think we're at the last parts of the randomized prospective study. We from Rothman also contribute a lot of patients to that study, and as part of that, we have done one-stage exchanges on some patients. Quite honestly, I've done about 26 of these one-stage exchanges, but I will tell you that the experience with one-stage exchange is better, but they're again hand-selected at the moment. One question that comes up, particularly based on Thorsten Gerke's recommendations on the podiums, that you really need to be able to deliver antibiotics with cement. The question is, can you do one-stage exchange with uncemented components? My personal opinion is, yes, you can. I know that the literature is divided, but you can certainly do uncemented, particularly with the hips. We rarely, if ever, cement a revision with a cement. So I personally believe one of the most important determinants of success, whether it's a one-stage or two-stage, is surgical debridement. And as George Tierney used to put it, you should treat infection like you treat cancer. Get safe margins, remove as much of the soft tissues as you can. So can or should one-stage exchange be done? Absolutely. It should be done. Do you need antibiotics and cement? Not in all cases, particularly in the hips. I think that the results have been so far fine. Who are the candidates? In my opinion, healthier patients who are infected with sensitive organisms. They have good soft tissue for coverage, and the surgery is being done in an organization or in a hospital where infrastructure is in place. Because doing a one-stage exchange is very different than doing a two-stage exchange. We usually remove all the infected tissues, the infected implants, cement, all foreign material. We will then debride the wound and leave povidone iodine impregnated swabs, and then roughly close the wound, take down all the drapes, remove old instruments, wipe the floor, bring in new instruments. Everybody goes out and re-scrubs, and we come back, open that wound, and then go through reimplantation. So as Tom Ferring puts this, it is like doing two operations under one anesthesia. So doing a one-stage exchange does require, quoting the words of Thorsten Gerke, a very different approach than doing a debridement alone. So thank you very much for your attention, and I hope I covered everything you needed me to cover there, Arun. Thank you.
Yes, thank you very much, Jay. That was a brilliant exposition on why you should do one stage. I have two questions really. One is, what is the role of the presence of a sinus in deciding whether to do one stage or not? Is that a contraindication? And secondly, do you need to use a hinge? Just like the endoclinic guys, they tend to use a hinge in most of their cases of one stage in order to be able to remove the collaterals and do a better job of debridement.
Thank you, Arun. These are very pertinent and important questions that continuously gets debated. The great news is that we will hopefully have the answer from this randomized prospective study. Presence of sinus tract was not a contraindication for doing a one-stage exchange. So we will have some patients with sinus tract who probably had a one-stage exchange, and hopefully the numbers are big enough for us to see if there is a signal or not. My personal opinion is if there is a real bad sinus tract, that's usually indicative of extensive soft tissue involvement. And if it is extensive, sometimes it's better to do a two-stage exchange in those, particularly if you excise the sinus tract and you're unable to do the soft tissue coverage at the same time. It does compromise the outcome. So I am less likely to recommend a one-stage exchange in patients who have soft tissue involvement, particularly those that might require a local flap. As far as the the hinge and the extent of debridement. I know that the Endo Clinic and some of those people have done extensive amount of work. But Xiao Li, for example, from China, does a lot of these knees without having to sacrifice the collaterals. And that's been also our thinking in the US, that you don't necessarily need to sacrifice the collaterals to be able to do extensive debridement. You can certainly go around the collaterals. And I've done some of these in about 7 or 8 knees that I have done. I ended up using hinge in only 2 and kept the others. And so far of those 26 I've done, none have failed. So I'm not sure. I know it's a very small number. It's almost a hearsay, but I am not absolutely convinced you need to be so radical that you have to take critical structures. And I consider the collateral ligaments as critical structures. But again, the randomized prospective study data will be able to answer some of those very, very important questions that you just brought up.
Javed, can I ask you a question?
Of course.
Javed, is the bud growing mandatory for one-stage revision? Can we push the envelope there and do?
Yeah. So it's a very, very good question again, Rob. The randomized prospective study in the US is including culture negative cases. And interesting thing is that I do next generation sequencing or other types of molecular techniques for isolating organisms. And some of these culture negative cases have infection with very, very unusual and potentially very difficult organisms. One case that I did a one-stage exchange on as part of the study failed. It was a culture negative. It's a personal experience. Unfortunately, that patient was infected by Mycobacterium abscessus. I didn't even know that organism before that. It's an incredibly difficult organism, causes extensive soft tissue destruction. So you will see that particular case in Tom Farring's series when he reports it. So to answer your question in a personal opinion way, I would say you can do it in culture negative cases, but you shouldn't have a culture negative case because now we have technologies that allows us to isolate the organism. Why not isolate the organism beforehand and then do the one-stage exchange so that we don't really fall asleep at the wheel and suddenly find out the patient is infected with something very, very bad like Mycobacterium abscessus.
Arun, can I ask Garrett? Arun?
Sorry, I had one more query, Jawad. Is it necessary to give long-term antibiotics if you're doing a one-stage? Because I believe, again, the endo clinic gives antibiotics for maybe for years after that.
So we're not. We're just giving them the usual treatment, which can be up to 3 months of antibiotics, but no longer. And the new MSIS criteria for success, which Yale Fillingham published on, would consider that as a failure. If you have a patient that still has their prosthesis, but you're suppressing them with oral antibiotics, that should be considered at least as type C or type D failure. So I personally don't think they need it lifelong. But there are circumstances, and I think we all have our hands tied occasionally when we've seen a patient that's had multiple operations and they keep getting infected with different organisms each time. I mean, I have patients that I have them on lifetime antibiotics, but these are not the first time one stage or first time 2 stages. These are usually the end of the road patients that have had multiple infections and now they're coming back, for their one last operation. And if you don't give them the suppressive antibiotic therapy and they fail, you're looking at salvage operation.
Arun, can I ask you?
Yeah, please.
Arun, is the fungal infection is a contraindication for the one stage, Javed?
In my opinion, yes. And that's been excluded from the randomized prospective study. Thank you for asking that great question, because the outcome of fungal infections is very, very difficult. And we can all speculate as to why that is. But one of the most important reasons is somebody who develops a fungal infection, usually as a result of their underlying immunocompromised status, which may be recognized and may not be recognized. Some of these patients may have what we call a primary immunodeficiency. they may not necessarily have those recognized causes of immunosuppression. Outcome of fungal infections, based on literature and some that we published, is really around 50 to 60%. To do a one-stage exchange in these patients, I think, is asking too much. In my opinion, it's better to give them a two-stage exchange. That's my personal opinion, but I don't think we will have that answer from the randomized prospective study either, because we did exclude the fungal infections from that cohort.
All right. That was wonderful, Jawad. It was really kind of you to take time out from your schedule in Italy. Thanks so much for being part of our meeting, and look forward to meeting you in person. Thank you so much.
Thank you, my friends. Thank you.
You know, officially get your family ready to enjoy the Hyderabad hospitality.
I am coming to see you, Professor Reddy. Thank you so much, everybody. See you. Have a great day. Bye-bye. See you.
All right. So with that, we'll move on to a panel discussion. I'll share my screen.
Arun.
Request Dr. Rajesh Malhotra to chip in if he's around.
Rajesh, are you there, Rajesh? Rajesh, I think I can see him on the panel. Rajesh Malhotra, can you hear us?
And the other panelists who need to join us are Dr. Vijay Kumar and Dr. Bipin Theruvil.
Yeah, Arun, if Rajesh is not joining, I'll ask Raju Vaishya from Apollo Delhi to join.
Yeah.
Raju, can you join?
Thank you.
Yeah, please join the panel. Yeah.
And I was going to actually request Dr. Vaidya also to join if he's around.
Yeah, sure. Vaidya, I think I've seen him somewhere.
But I mean, feel free, all of you all, to chip in. So let me start with the screen share. Not sure what's happening. Are you able to see my screen?
Yeah.
Yes. All right. So the plan is to really talk about three scenarios. One is the post-traumatic stiff knee, failed HTOs, and failed unis. And this was inspired by Dr. Pachre, who suggested this. So let's first talk about post-traumatic stiff knee. Now, this guy is a 76-year-old male, BMI 28, hypertensive, 2 years following this open reduction. And he has a stiff knee, 10 to 70 degrees range of motion. His ESR is 28, CRP is 2. So how will you proceed? I'm not going to address each panelist. Just speak out. Whoever would like to chip in, just go ahead. Dr. Vaishya, you need to unmute. Is Dr. Vaidya there? Dr. Rajesh Malhotra, he's also mute, I think.
Rajesh is not there.
Yeah. I'll take on. This is Dr. Vijay here. Yeah.
Okay, go ahead. Yeah.
Yeah. So this is a 2 years post-op. I think, Dr. Arun, you have ruled out infection as the ESR CRP looks to be fairly normal. The fracture, this is an immediate post-op X-ray. As I can see a drain there. I think it might have united by the time it has come to you. Is it so? Because the lateral view shows a drain there.
Correct. No, this is 2 years. The AP is 2 years post-op.
Yeah, so it looks.
I didn't have a good lateral, so I've used the immediate post-op that I got.
Yeah, sure. So this looks united. Maybe, we would like to see a whole, a scanogram sort of thing so that the whole alignment can be seen, whether it looks like going into valgus. And this was a fracture, you said? Yeah. Maybe if you have an X-ray, the whole, a long limb X-ray, a scanogram sort of thing so that the alignment can be seen.
I'll show that to you in a moment. The key question I want to ask you is, one, would you stage this procedure? Would you first remove the implants and then go ahead and do a total knee replacement at the second stage, or would you do it in one go?
Yeah, so, if I'm suspecting an infection, then definitely it has to be 2 stage. So in the first stage, I go in and, take out the implant.
When will you decide? How will you decide that?
Yeah, the markers are there. The markers are all right. ESR 28 and CRP is 2. And there doesn't seem to be much of osteolysis, although I can see a little bit on the medial side. But and the incision, where the incision is, if it's dead lateral, so the plate has to come out to a separate incision, and the knee replacement has to be done to a midline incision. Then it's better to do it in 2 stages. Remove the implant first, and especially if you're if you have any suspicion of infection there.
All right. And how would you rule out infection? Besides ESR, CRP, would you do it differently?
Yeah, you can do a joint aspirate. You can see clinically if the joint is swollen, or that is one thing. Those are the only thing. A bone scan would not really help much in this. You can do a leukocyte labeled bone scan. Nowadays they do FBG PET also, but I'm really not very keen, and not it would not really rule it out.
Okay. Any other views? Anyone else? Would anyone do it in 1 stage?
Dr. Arun, I would also do it in 2 stages, because our questions are: is it infected? Is the fracture healed? And ESR and CRP, all these are surrogate markers for joint replacements. These have not been validated for fracture fixation as such. So I would still suspect that this could still be infected. So I would, my preference would be do a 2-stage, because that will give me a chance to do a midline incision as well.
All right. Okay. So let's move ahead. So this is what we did. We did exactly like both you gentlemen suggested. In the first stage, we removed the implant, and here's a full-length X-ray now at your disposal. So you can see it's a significant valgus deformity, a fixed valgus with a stiff knee. So how would you, what sort of implant would you use? You already mentioned a midline approach, probably taking it perhaps a little more medial than closer towards the original scar, so that you have a wider bridge of skin in between. And there is quite a bit of valgus bowing of the femur as well. So it's a significant deformity. So any suggestions, what type of implant, any particular releases that you would do?
This one I would again go, I'm more familiar with a medial approach. I would go to a medial approach, and the deformity here, unlike most of the valguses, will be more in the tibia as opposed to the femur. So I would do the tibia first, cut my femur based on the tibial cut, do a release of the posterior capsule, do a release of the lateral structures if required. I would go for a cruciate sacrificing implant if required. I don't think a stem would be required. It's a small, the screw holes are not that big. So I would probably go for a standard implant.
All right. Any other views? Guruva, Dr. Pachure, anything else?
Arun, I just wanted to know from the veterans, how do you gain the flexion in a stiff knee? A quadriceps plasty, I want to know.
How do
you get flexion in a stiff knee? Whether you do a quadriceps plasty or you do the stab incisions, or what is your protocol?
So it depends on how severe it is and where the problem is. If there is some obvious problem like a posterior osteophyte, or whether it's a question of anterior contracture.
Anterior quadriceps contracture, typical this one.
If it's a quadriceps, then you do a quadriceps plasty.
Yeah.
The way in which I do it is the way in which we used to do it in our medical college, in our KEM hospital, where we would detach the vastus intermedius and remove a segment of that, and then pie crust the rest of the rectus and gradually stretch it out. So that's the way in which we would do a quadriceps plasty and get more flexion. All right. So this is what we did. There are screw holes and there is a potential of stress fractures from those. So we would like to bypass that and at least protect them with a stem. So this is the navigated total knee. You can see we used a straight midline incision. And by then, of course, the wound had healed, so we didn't have any issues with this. We did this 6 weeks later.
What type of releases did you have to correct the valgus knee?
So in a valgus knee, this did not require any osteotomy. Most of this gets corrected if you do an IT release as well as a posterolateral corner release. Most of the times that is sufficient. Now this is the next case, gentlemen. A 63-year-old male, 6 months after internal fixation with a very limited range of motion, ESR 78, CRP 24. You can see the situation, the knee is pretty bad and arthritic, as well as you have a plate and you have a non-union. So how would you take this on? Dr. Bipin?
Yeah, my questions again stand the same. Is it infected? Is the fracture healed? The answer to both the questions is, I think it's in the negative. This looks infected from your ESR and CRP levels, and it has not healed. So first thing would be to find the bug of the organism. See the bug here, which probably I would do it with aspiration. The fracture has not healed. So at 63, my feeling is that these condyles, there is a large gap. To make it heal would be a bit difficult. So in the long run, we are looking at some form of a distal femoral replacement. So I would like to do it in 2 stages. First stage, I would like to take all the implants, the distal femur out, probably, and find multiple samples for culture. And in the second stage, I would go for a distal femoral replacement in this particular patient once the ESR and CRP has settled down after around 6 weeks of antibiotics.
Okay, any other views? Anyone? How would you maintain the gap once you remove the distal fragments? Because they all look pretty infected.
I would do complete excision of the distal femur. And in the second stage, I will do a tumor processor.
All right. And how do you maintain the gap?
Yeah, we'll put antibiotic spacers.
Spacer. Okay. All right. Okay. So that's precisely what we did. We removed all the muck, all the distal femur, all the fragments, the necrotic fragments, sequestra, implants, everything, and put this in. You'll also notice that there was a popliteal injury at the original time, and this is the stent that was applied at that time. We have to be a bit careful about it. And this is his eventual second stage, where we did a distal femur replacement, as all of you mentioned, a hinge type. So quick summary, do not take total knees for post-traumatic OA lightly. There are several challenges. Many of these are young male patients with scars, hardware, bone defects, malalignment, stiffness, ligamentous problems, malunions, non-unions, often retropatellar adhesions, and even patella maltracking. Now, in terms of scores, range of movement, and survivorship, there's no significant difference, but the complication rates are much higher than standard PKR for any other cause, for primary OA, for example. And the complications include infection, stiffness, manipulations required, ruptures of tendons, especially the quad tendon, wound complications, osteolysis, wear, instability, and aseptic loosening. So meticulous planning is required in these patients. You need to do a proper infection workup, and you also need to assess the soft tissues and have hardware removal instruments ready and select your implant. Most of the times, a PS implant, you may need constraint or a hinge at times, and very rarely a tumor prosthesis. And you may do it in 1 or 2 stage. You have to look at the soft tissue conditions, scars, the presence of implants, and if you're concerned about infection, it's safer to remove the implants, send material for culture, and wait for 6 to 8 weeks. So take care in post-traumatic OA knees, plan carefully because it's pretty challenging technically, and there are potential risks of complications. And you must warn them that the outcome, range of motion, and survivorship may be somewhat lower. failed high tibial osteotomies.
How do you remove the spacer? Do you cut the nail or remove it? The one question.
Very easy, because the cement has so much of antibiotic that you can just fracture it with an osteotome. Not usually a problem. So this is a lady now, 61, BMI 34, diabetes, 5 years post high tibial osteotomy on the left side. And this is how she presents. These are her further x-rays. So what are the issues that one faces when we are dealing with a post high tibial osteotomy patient? Would you like to tell us, summarize the technical challenges that you face?
Yeah.
Vijay, can you
Dr. Vijay Kumar?
Yeah, sure. So, it starts right from the pre-op planning. If there's an implant, you always rule out infection. First dictum. Second, that, there are multiple incisions there. If there is a lateral incision, try to take the lateralmost incision. If you want to do it in a single stage, right? Always get a whole length X-ray done pre-operatively. Once you have taken the patient to the operating theater, then the exposure is a little difficult in these patients because most of them have a patella baja because of the scarring. The infrapatellar scarring is there. So, subluxation of the patella or the eversion of the patella is a problem in these patients. So, that time you should be versed with the extensile approaches such as a quadriceps snip or a tibial tubercle osteotomy. Then, you should always have, constrained implants whenever you are planning for a, conversion of a HTO to a TKR. You might require them. Then sometimes the canal is offset. So, if you are planning to put in a stem, you should also have a offset stem along with you. And if, a PS implant has been shown to be better than a CR implant in these patients because the proximal tibial, anatomy is disturbed. So, the PCL may not act as it does in a CR knee. Then, the slope, you have to be careful with the slope of the tibia. Sometimes it is, it is reversed, and sometimes the slope is much more, so you have to be careful with the slope of the tibia also. And I think these are the major things. And the placement of the tibia.
Pretty well. I think you made a very good long list of problems that can be faced when dealing with an HTO. And this is what we did. We did it in stages. We did the right one first because that was more symptomatic. And then we did the left one where we used just a standard PS total knee arthroplasty. And this is her clinical picture. So just to summarize what you said, this is on the screen now. Problems are prior incisions, hardware, joint line gets distorted. You can have malunions and non-unions to deal with. Patella baja, you mentioned the offset and adhesions. Occasional peroneal palsy can occur, and infections. So these are problems. You've got hardware, the tibial slope can be reversed, non-union, you can have overcorrection, or you may have residual varus deformity. Again, you can see the patella problems, patella height and adhesions, and also the tibial offset. But more importantly is the reversal of the joint obliquity. And this occurs whether it's a closing wedge or an opening wedge. You can see how the joint slopes outwards and laterally. And you've got to take that into account when making your tibial cut. So not only the posterior slope, but also the mediolateral slope may be considerably altered. And that may lead to problems with your implant position. So here you can see the implant is malpositioned somewhat in valgus because of the deformity in the proximal tibia, which can mislead the component. So that brings us, any other points that you would like to add, Dr. Pachare, Dr. Guruva, or any of our faculty?
I would feel conversion of unicondylar to total knee is much easier than H2O to total knee. Am I right?
Absolutely. I think you said it spot on. I think HTO, just like post-traumatic cases, I think can be very challenging, and there are a host of issues that you need to be aware of and not walk into this very lightly and underestimate the potential technical challenges. You've got to be well prepared and plan it out very nicely.
Arun, can I?
Yeah, of course.
Yeah. See, a lot of these STO people are now, that they are doing open osteotomies from the medial side, and they feel that you have no problem of anatomical changes, what we had in closing osteotomy. Have you had any experience of operating post-STO with the open wedge osteotomy patients?
Yeah, we have had experience.
So what do you think about it?
It's equally challenging because, they have altered. Your original bone loss is medial compartment. So you have medial contractures. Then they have gone ahead and opened it up medially. Your joint line is sloping laterally. So it's sometimes quite a nightmare to balance these perfectly and align them well. So you've got to do a lot of pre-op planning to understand how you're going to make your cut, how much you're going to resect, and make sure that you don't alter the joint obliquity too much or the joint line height and end up with patella baha.
The same thing with our here experience. We had done a couple of them which had open osteotomy. It's a really nightmare. It's not that simple what the STO people are recommending actually. The hardware is very, very difficult to take it out. So these are locking screws,
Yes.
And the open wedge area becomes so sclerotic. So it is very, very difficult to negotiate the steps,
Correct.
Yeah.
So it's not that easy as people make it out to be. And you always have that risk of infection. There may be a rotational problem, which I have not depicted in these slides. But, the upper tibia can be rotated vis-a-vis the lower tibia. So that again can lead to either in-toeing or out-toeing because you haven't got the rotation of your component right. It's a fixed pairing. So that's another 3D problem of rotation. So
Arun, can I just come in and mention one point here sorry, this is Hemant Tuakankar. Hi.
Of course, Hemant.
Hi. Just one point. I believe that post-STO TKRs are one of the most difficult to balance, especially in flexion, because in order to cut perpendicular to the long axis of the tibia, you end up taking out much more bone from the medial side. And if you want to get the femoral rotation, even slightly external rotated, even 3 degrees, that actually leaves the medial side quite lax. And especially in overcorrected high tibial osteotomies, those are, I think, one of the most trickiest to balance. And those are the ones actually one can end up having a lateral popliteal palsy. Especially they behave like a fixed valgus knees.
Yeah. No, it is pretty challenging. And also most of these have been done with oblique incisions and all sorts of nightmares because, you have to take perhaps a little longer incision, or you have to do a less than ideal midline incision because of a previous scar going in an oblique fashion. So that again creates a problem, and anyone doing tibial osteotomy should please try and do either transverse incisions or pure vertical incisions and not use angular incisions because they can create a lot of problems with access. All right. So thank you for your comments, all of you. And now we come to the last part, which is failed unis. So this lady had a uni done 3 months ago somewhere else, presented with severe pain, 63-year-old, BMI 29, no comorbidities. And that's her X-ray. And what do you think has happened, Dr. Bipin?
The tibial side has definitely subsided quite significantly, possibly because of, I think, what I can see, like a fracture around the medial tibial plateau, which is not uncommon. So I think this obviously it's an unstable situation. The femoral side looks okay. I would rule out infection. If there is no infection, this definitely needs a revision. Now, my problem is going to be the big defect on the medial side. I don't know whether an augment will take that. I'll need to measure it properly, template it properly. if it's enough to accommodate the largest augment, I would just use a largest augment, stem the tibia, do a standard cruciate sacrificing knee on the other side. If the defect is too large, I will probably go for a sleeve and revise the tibia using a sleeve on that side.
Okay. Any other thoughts?
Yeah, Arun, can I ask Raju Vaishya to give comments because he's going to. Yeah, Raju.
I mean, there is a fracture and a lot of bone loss on the medial side with the large defect. So in such a case, when you're revising, we have to build up the medial side using augments and as well as a long stem. And obviously, to correct the varus, we have to do proper release. Varus release.
So I think this was an intraoperative fracture which I think got missed, and that often happens if you either have your vertical cut while making your tibial cut. The vertical one, if it goes in too deep or it penetrates the posterior cortex, it creates additional stress and can lead to this medial condylar fracture, periprosthetic. Quite often, there's a fine crack which may be missed unless you look at the X-ray carefully. Patient continues to walk on it, complains of pain, and over a period of time, it goes into this varus deformity. So as you all rightly pointed out, once you rule out infection, you then need to decide how you're going to take care of this problem. If they come very early on, I have actually fixed one of these condyles, and they have gone on to do quite well. But unfortunately, the patient presents late like this, where substantial amount of subsidence has occurred. Then you have no option but to go ahead and convert it to a total knee. So here are some intraoperative pictures showing how we prepared the site. We removed the failed tibial component, and we have prepared a step cut defect. You can see on the right side is the femoral preparation. So usually the femur does not have any major issues, and there may be some residual, bone defects which you can graft. So you can see some amount of grafting has been also done in order to make sure that we can use an augment and we don't need to put in a sleeve. So this is what we did eventually. You can see the augment sitting quite nicely. And we protected it with a stem and a PS knee and restored the overall alignment to what it should be.
One practical tip, Arun, which you showed on the slide, you retain the femoral component until the last minute.
Yeah, so you can keep that and also make sure you don't get misled by the missing posterior condyle on the medial side.
You reference on the femoral component.
Yeah, you can retain the femoral component and then go ahead, prepare your cuts, and make sure that you take into account the fact that the posterior condyle is missing. Otherwise, you may malrotate the femoral component. So that's a post-op. So now this is the next patient, 95 kg female. She fell 3 months post-op. That's what she told us. These are the x-rays on the left side, which are the immediate post-op x-rays. And she presented almost a year after this episode with the x-rays on the right. You can see a massive amount of subsidence of the tibial component. The femoral component is intact. The immediate post-op x-rays are shown there, which show no obvious fracture, crack, or anything untoward. So when she fell, she obviously had this fracture. And surprisingly, these people actually walk on this for quite some time. They have some degree of pain, but they can continue to walk. And she continued to walk on this and presented a year later. So now how are you going to deal with this? Any thoughts? Dr. Vaishya, you think a sleeve stem would work here? Or an augment and a stem? Dr. Vijay Kumar, what do you do?
Yeah, this would require
Raju is Indrajit, you want to take the question?
Yeah, this would require.
Indrajit, you want to take that?
I don't know. Is he there, Dr. Raju?
If Dr. Raju is not there.
Raju is not there. Indrajit Sardar is there, Arun.
Yeah, Dr. Sardar, why don't you tell us what do you do?
This, I think, would merit obviously removal of the thing, and probably then I'll see. You've already shown what you do.
Sorry. You're trying to click something.
Anyway, maybe I would not have gone to that extent.
Okay.
I tried it out with a augment, but if that is not succeeding, then possibly a sleeve.
All right.
Of course, a stem.
Yeah, so it was a huge defect, and therefore we opted for a sleeve. The only thing I would think is probably that stem was a bit too long. For some reason, we took in a longer stem, probably because of the bone quality. But, perhaps you can use a shorter stem. And that was a huge fragment which had collapsed.
Arun?
Yeah.
Let me ask you a question. In fact, morning only one of the fellows was asking me, when you use a sleeve, there is a big gap between the medial part of the platform and the tibia.
Yeah.
By putting cement, are you negating any biomechanical principles, or you can put that cement, or don't bother?
Well, I worked very closely with Robert, with Dickie Jones, all right? And he was the original designer of this. And he said that at times he had put cement initially, then he stopped putting cement in the gap because it prevents subsidence. You want these sleeve to engage in the cancellous bone in the metaphysis. So if you cement, then you're not allowing that to happen.
Yeah, so it's biomechanically counterproductive.
Biomechanically doesn't make sense. So unless you want a pretty X-ray and you don't want that gap to be seen and relatives and patients asking you why this gap, then you fill it with cement. In a very elderly, low-demand patient, if the bone is very osteoporotic or you're not sure about the stability of the sleeve and you have impacted it a little less in very osteoporotic bone, you gingerly impacting it, then you could layer it with cement in a low demand patient. But in a younger person with good quality bone, he would suggest that you don't use cement.
Yeah.
All right. Okay, and the last one, this was a bilateral case done in a 57-year-old female, and this is how she presented. ESR, CRP normal, no comorbidities. The fixed bearing knees and pretty badly deformed, subluxated, probably a poor indication for this type of surgery.
I think the patient selection was quite wrong here, as you rightly said. I think especially on the right side, it's subluxed knee. So here you would, in ESR-CRP normal, you rule out infection. So standard revision principles would apply here. Again, the defect is on the tibial side looks, possibly you can use an augment. I would keep a sleeve on standby. Femoral side, again, the defect is not too huge. So I would, keep a stem on standby, but may be able to get away with a standard femur with a stem on the tibia plus an augment on the tibia.
And you'd use a PS or a more constrained implant?
Here, somehow that right knee to me looks like it will need a more constrained implant because it's subluxed. I think I'll play it safer with the LCCK type of implant.
All right. Any other views, Dr. Gaurava, Dr. Pachure, Hemant, anyone?
I think you already showed the post-op X-rays. I would go the same way. I think the wedge. Yeah.
All right. So that's what we did. We used a PS on both sides, was simultaneously done. And we navigated, and these are the images of the patient following surgery. So about 5 to 34% of unis, depending on which paper you read, when you convert them to a total knee, may require revision components. So about probably not more than 1/3 would need it. In terms of conversion of a uni to a total knee, the outcomes and complexity of conversion will depend on the reason for failure. But as everyone has pointed out, it's probably easier than doing a conversion of an HTO. And these conversions may need revision implants, as I said, in one of 3 cases. The outcomes of conversion are comparable to a primary total knee in large matched series. And results and complications of conversion are comparable to a revision of a failed total knee to a total knee, but with a higher risk of revision and higher infection when you're converting a total knee to a total knee. In other words, if you have to convert a failed uni to a total knee, as against a failed total knee to another total knee, the second option will have higher risk of revision and more infection. And this is from a large series. All right. So with that, I think we've sort of tried to make up for the time that we've been running behind by.
Arun, one caveat. I'm going to speak tomorrow, the President's talk.
Okay, perfect.
So I'll invite Hemant to do the last session.
Yeah. So Hemant, thank you so much for waiting patiently, but it's only because Guruva told us that, the discussions should go on because the faculty is great and so on. So it's all the President's fault.
Of course it is. It always is.
Yeah. But I thought half an hour overshoot is okay because the value we get is very enormously good. Wonderful. I'll give my talk tomorrow, President's talk. The title is How to be a Happy Orthopedic Surgeon.
All right.
Yeah.
No, thank you. This slide actually is, my photograph is 15 years old and the information is 10 years old. So I'm sorry about the information there. All right. So there's a digit missing there. Anyway, I have a case scenario panelist today in the form of Dr. Raju Vaishya, Dr. Indrajit Sardar, and Dr. Ravi Kumar. I believe all 3 are logged in.
Hemant, Raju has left for some purpose.
Okay.
Vaibhav Bagaria is there.
Vaibhav. That's fine. I'll have Vaibhav with this case.
Vaibhav.
Let me share my screen. If I can share my screen, please.
Yeah. Meanwhile, Vaibhav, are you there? If Vaibhav is not there, Dhanashekar. Dhanashekar? Vaibhav? Vaibhav?
Yes, sir. I just joined. I just gone. So I didn't.
Can you join the discussion? Panel discussion. Okay.
Sure, sir. Sure.
All right. Can you see my screen?
Sure.
Yes, sir.
Yeah, I mean, my brief was to have cases on these 4 topics. Now, all these 4 topics are massive in themselves, and I think I can only touch upon very small aspects of these. So, without much ado, let's move on. This 70-year-old patient presented to me 2 years following his primary knee elsewhere, and this is the way he was walking. And he said he's been walking like this ever since his primary knee. And, just looking at it, what's the first thing? Vaibhav, what do you think, you comes to your mind first? What's going on?
Yes, so definitely there is a thirst, and it suggests that the balance is not appropriate.
Yeah, so that's the first, thing that comes to your mind. And then you look at the X-rays, and these are the varus and valgus stress views. So again, something unusual, you think, for a primary knee done 2 years back, and ever since then, the surgery patient has never been happy.
Right. So you can clearly see that there is quite a bit of opening on the lateral side.
Yeah.
And so
it's unusual to have such large lateral opening and lateral incompetency. I mean, we always talk about medial collateral giving way during surgery and things, but lateral incompetency is unusual. So I went through his other records that patient had, and as it appears, this was a routine varus knee. These are the pre-operative scanograms the patient had with him. And one important clue that the patient said, that patient was put in the plaster after the primary knee replacement for 3 weeks. And there's an X-ray, in fact, in a plaster. So what again, does that change your opinion, Vaibhav?
Yeah, so clearly at that time, probably he had a lateral condylar fracture, which was diagnosed on table perhaps, and that is one of the reasons why this instability has persisted. So So
yeah, I mean, 2 years he's been walking like this. I suspect probably not a lateral condylar fracture, but probably the lateral, all the structures have been iatrogenically severed at that point, I think. I mean, you don't see any, fracture, no evidence of a fracture on, at least on the X-ray. Indrajit, do you think anything different?
Yeah, lateral femoral condyle.
The key thing over here is that he was having it right from day one.
Yes, that's right.
That means there was something wrong during the primary operation. And possibly what you're saying is absolutely right. There was a lateral structure, something had happened to it.
Right. So what's the solution now, Indrajit?
The solution would be to obviously revise the entire thing and then go on for a constrained implant. Probably that will work.
Yeah. The degree of constraint, we always talk about doing a CCK or LCCK type of or a TC3 type implant as against doing a hinge. Now, what are these issues on which you decide whether you want to go ahead all the way to the hinge or you can get away with a TC3 or a LCCK? Dr. Ravi Kumar, you're logged in as well?
Yes, sir.
Yeah, please.
Yeah. I mean,
what are the
yes, sir.
What are the factors on which you decide this?
Yes, sir. Where if flexion and extension gaps are not managed either with semi-constrained knees like TC3, then I'll go for hinge. And if there is a incompetent or cut LCL or medial structures or lateral structures, I'll go for a hinge.
Okay, fair enough. Any differing views, Indrajit, Raj, or Vaibhav?
Sir, would you get a CT for these patients just to see if there is a non-union on the lateral femoral condyle? Because
would that change your plan?
No, of course, but any information that you have, it will help if it's a non-union.
Yeah, this patient came to me, 2 years following the primary surgery, and I was quite clear in my mind, lateral ligament complex is incompetent, and just to show you on table as well. So that is the kind of thing is, and this is what was done. He had a LCCK done, and that is his follow-up at 2 weeks, and his stability is restored, and the problem has been solved. So I think most of the times I will decide whether I need a LCCK or a hinge based on the residual, soft tissues. And in fact, laterally, if it is incompetent, it's not so much of a big issue because many times TFL, tensor facial aorta, tends to be intact. But if the medial side is completely incompetent, one actually has to go for a hinge rather than TC3 or LCCK type. That is at least my ballpark with respect to the constraint.
Can I add to that?
Next is this lady. This is an elderly, low demand 85-year-old lady who had a fall domestic in the kitchen and presented with this X-ray picture. Indrajit, what are your options at this stage? What are the types of reconstructions that you can envisage here?
Probably if it's come very early and I can look at the fracture lines properly, I could try for an osteosynthesis in this case, preferably if it's an open box type of femoral implant by doing a nail.
Okay, Vaibhav, any differing views?
Sir, the algorithm for these fractures are very clear. You have to decide whether the implant is stable or loose, how far is the fracture line from the anterior flange, so as to enable you to see that whether you can fix them or not. So these are the two critical issues that you need to know. You have to assess, you have to of course keep all the inventory ready for such cases, because sometimes despite everything, even if it appears to be fixable, you need to kind of have a bailout option with distal femoral replacement.
But if would you be going for a fixation in this kind of a scenario?
So again, as I said, I'll get a CT done. I know you may not need it, but if it is 20 millimeter away from the anterior flange, because sometimes this could appear that it is just there, but you may be surprised the amount of bone that is still present, because this is kind of telescoped. So you don't get a clear picture. Either you get a traction view to see if there is some bone. So earlier I used to be very dogmatic that such patients can't be fixed. Having worked with Dr. Tanna, I've kind of changed my mind, and some of these, although seemingly may need distal femoral replacement, can be salvaged with a fixation as well. provided you have got all the information necessary.
Okay. Dr. Ravi Kumar?
It all depends upon the bone stock, sir, as rightly told. So I would like to do a subtraction CT, understand the bone stock. If the bone stock is good and open box, nail and supplementary plate if required. If bone stock is poor, I will go for distal femur replacement.
CT scan is a waste of time.
Yeah, elderly, low demand patients with extremely porotic bones, and this kind of picture. I think most of them, we have tried our hand at fixation many a times, and most of them end up in having one more surgery in the form of revision. And frankly, in an elderly, low demand patient with this kind of picture, I do not bother with fixation because we have burnt our hands a few times. And this is the kind of bone that one is left with.
Can I make a comment, sir? I think what has changed is that earlier people used to only put a single fixation, and that is why most people burn their hand. If you do a dual fixation in such periprosthetic fracture, either a nail plate or a dual plate, and if you had a good bone stock, these fractures do reasonably well. And as I said, the individualistic, it's no harm done by.
Can I add a comment on this?
Yes, please.
We got one of the largest series periprosthetic fractures. In fact, we are writing a paper, 75 cases are there. And I rightly agree with you. I just decide on the age of the patient and the bone stock, that's all. CT scan is a waste of time. You go ahead and put a hinge because hinges are got a greatest results now. Only the Vibos agreement comes into play if the patient is between 60 or 55 to 60. Then dual plate is much better than a single plate. That is
again, you need decent bone stock with the prosthesis itself. You need fixability there. You need some decent bone there.
There's no way CT scan is going to give you an indicator of that. You got to prepare for both. Preemptively tell the patient that I tried this or that, and then go in and decide on the table. There is no way CT scan is going to give you a clear-cut pathway. CT scan is very.
Yeah, if you're going in for arthroplasty or revision arthroplasty here, what kind of implants you would talk about today? What are the options you have available? Indrajit?
Over here, then if I'm going to go in for a replacement part of thing, then you can have a tumor prosthesis. Or else the other thing would be to do a rotating hinge type of thing with a femoral stem and a
modular hinge.
Yes.
Yeah, those are the options, and even a sleeve could be used here. Sleeve, from DePuy could be used here as well. So these are the, I think, 4 options that we have available today. I mean, I personally, use rotating hinge many a times, especially like this. Obviously, the stem has to be fully cemented, and this becomes a one solution for these elderly ladies. They get on their feet very quickly and mobilize very rapidly and have good outcomes. And I think these work pretty well. And I think so. As you mentioned, Guruva, that age of the patient becomes critical. The activity level becomes a critical aspect of the decision making.
Hemant, can I just?
Yes, please.
Yeah, two, 3 things. The intrabody nail for these patients are not good because there is no distal hold. I think that is absolutely a waste of exercise. Regarding what you said, age is absolutely mandatory. But if this is a younger patient, what Weber was talking was dual plating. When patient do not have the medial bone, Hemant, then you put a medial plate. If the patient has a good medial bone, you don't require a dual plating. So this is one thing we have experience of having a dual plating. Whenever there's a medial combination, then you buttress the medial side. But these are all younger patients. I totally agree with all of you.
Yeah, if there is decent bone stock with the prosthesis, then I think fixation is an option. But again, you really need to compress that fracture and try to get it together. Going for an anatomical fixation many times itself is a problem because there are so many there's so much of crushed bone and gaps in the fracture side itself.
Yeah, but Pachare sir, it is now biomechanically and literature-wise very well established that dual plate is better than single plate in any supracondylar femoral fractures.
I will send you a couple of X-rays, Guruva. If there is a medial combination, then you buttress. If there
it's not buttressing, sir. What I'm saying is
shear forces.
You're not giving the complete things. The failure of the dual plate is far less vis-a-vis single plate.
I agree totally. I agree. I'm not saying no. But most of the time, there's a medial, there's no bone left. That is the reason
there's no bone, you can't put the plate, sir.
Yeah.
Okay.
Right. This lady presented to me having had bilateral knees done elsewhere, that her left knee was deforming slowly. She presented to me 2 months after the index surgery. And she said her left knee has been progressively deforming as she started walking. She has had no fall. She has had no injury. And these are the x-rays that she presented to me with. Vaibhav, what's going on?
Yeah, so I would like to clinically assess what's going on. Of course, whether it is purely a ligamentous thing, whether it is alignment or...
What do you think on the x-ray?
Yeah, I think, again, it seems to be an osseous issue there because if you look at the poly gaps on both sides, they don't seem to have changed. I think it's the component malpositioning along with probably, again, as I said, some condylar fracture, lateral condylar fracture. So it's an osseous thing that's going on there rather than a ligamentous thing. Instinctively, it would seem like an MCL getting gay, but looking at X-ray, I think it's the lateral condyle which has given away.
If you see, the X-ray ligaments are absolutely right. Only the bone is gone outside.
Yes, so it's an osseous thing. Yes.
Yeah, so it's a lateral condyle that is crushed, and this was a navigated knee. You can see the pins of navigation there, pinholes of navigation on X-ray. This was the post-operative X-ray. Indrajit, any comments from this X-ray to the, in a matter of 2 months, that is a stage without any fall?
Yeah, there is a lateral condyle fracture, and the ligaments do look okay. And but this thing, I would still do this is not a stress view, I believe.
No, this is not a stress view.
If you take a stress view and it goes further on, then I'll have to think of a medial collateral injury, which will be the most common. But now in this situation, open up, provided the ligaments are intact, see it, fix the lateral condyle, and see what can be done. And on the tibial side, of course.
Okay, this was the view on exposure. The lateral side, the lateral, cortex and lateral epicondyle are intact there, but this is the kind of a gap that one is left there. And the lateral condyle has been completely crushed in. Dr. Ravi Kumar, what's the option here?
So I would like to plan like a TC3, like an implant, semi-constrained, if required, a sleeve, sir.
Okay.
Sleeve.
Now, this patient was done almost 15 years back. These images almost 15 years back. At the time, we had no sleeves available. Okay. But the TM cones had just come in. So I had kept the TM cones available and tried that trial on, but even the smallest TM cone was too big for this femur. So TM cone was, as an option, was ruled out. And we had to do with using a long stem and rotating hinge. That is the defect one is left with. So that defect was cemented, and that's the metaphyseal cementing and a postoperative. This is in fact a 1-year follow-up of this patient. Any comments, Vaibhav?
No, I'm a bit, in these days, I'm of course hesitant of using cement on that thing. So I don't like that. So
no, remember this was 15 years back. We didn't have too many options available.
That is why I said now in these present times, I would have really given a Snyder remark on this.
Yeah, I would have used a sleeve there. There's obviously a
lot of sleeves. And then even at those times, maybe some kind of allograft, I don't know. I mean, as I said, at these present times, it is not acceptable. But if it's a good result, we can't question a good result.
Yeah, but
a long-term follow-up is a good result.
There is one technique in the good old days. I'm sure still some people follow that. You make that cement as a wedge, a separate wedge. Yes. You put it like a wedge, make it like augment, and put it, and then fix it with another bout of. Yeah, you just don't pack it. You make a wedge, let it harden, and then push it back as
it's a cheap augment. The cheap augment that you create for yourselves.
Rather than just pushing the cement in.
Yeah, I mean, this was a 1-year follow-up. I mean, in fact, when I had shown this post-op X-ray to somebody, senior surgeon had commented that this is going to fall apart in 3 months' time. But this is a 1-year follow-up, so, well, something is right there.
You're lucky, I mean.
Yes. Right. Just a small word. I mean, we're already running very late. I'm not going to go into the details of infection. I just want to know about the protocols that each surgeon follows. And in case of, for example, this lady presented 5 years post TKR, sudden onset of pain and swelling. And there are two scenarios that one can discuss here. One is a patient is not on antibiotics or has been put on all antibiotics already. And how do you approach these patients? Why, Bob? Let's consider patient is not on antibiotics. The protocol is, it's a virgin field for you. You can do what you like. So what's your approach in this?
Of course, we need to get a culture for this patient. I mean, of course, it does look like an infection. So, of course, apart from the lab investigations, a culture is mandatory to get an organism. If we get a culture which is positive, and if we...
What are the samples that you send for? What are the things that you order when you send a fluid off?
I send for everything. I send for pus for smear, synovial fluid for number of pus cell per high field, smear, culture.
And what's the cutoff that you follow now?
So I still follow the old 5 per high per field in at least 3 fields.
No, that would be histopathology. That would not be, you're talking about the number of WBCs in per cc. And that cutoff has been coming down from, say, 5,000 to 2,500 to as low as 1,500. Javed Parvezi, came down with, I think 1,700 was last I heard.
Yes. Yeah. So
you're sending off fluid for smear. You're sending it for culture, aerobic, anaerobic. What else?
Fungal tuberculosis and
fungal tuberculosis. Yeah. And save the specimen if you need to for gene expert.
Yes. Yeah.
Yeah. And so that would complete the spectrum. And what would you do if, say, patient is on antibiotics?
I would still correct a culture, but I would see if the general situation. So blood culture is also collected for all of these patients just to see if there is a bacteremia.
Yeah.
If it is safe for the patient to be off antibiotics, and if I feel that's some chronic infection, then I would put the patient off antibiotic and try to get a culture, because that will help me decide whether I can do a single stage or 2 stage. We have just started doing next gen sequencings. So hopefully with even on patient on antibiotics, I think it's early days for us to know whether being on antibiotics or without being on antibiotics will make a difference or not. So if the next gen sequencing is helpful, genome sequencing is helpful, it won't matter to us as long as we get to DNA.
No, I think if patient is already on antibiotic, you still have to go ahead and send all the fluids off for culture.
That has been done. Yes.
And I think just the look at the fluid itself tells you immediately what your next action should be. Because if this is a very sudden onset, it's most likely a hematogenous infection. Obviously, you'll get an X-ray done, make sure this is not a chronic, infection. Mm-hmm. But if this is a sudden onset of pain and swelling and redness, that is usually hematogenous, and there is still you are still in that window period where you could salvage these processes. Dr. Ravi Kumar, your opinion?
Yes, sir. As you rightly said, acute and chronic, most of the delayed infections are hematogenous. According to Coventry, anything happens after 2 years is a delayed infection. And unfortunately, the delayed infections are very low-grade infections, very difficult to find the bug. So as soon as the patient comes, better to aspirate and send it and plan for the arthrotomy with this much swelling and raised CRP. So depending upon the extent of the infection, we divide if the patient is already in antibiotic, as you rightly said, if you are doing a first stage revision, we send the implants also for sonification. We divide the tissues into 3 things. First is fluid, which is sent for anaerobic, aerobic, bacterial culture, fungal, gene expert, and if required, the molecular sequencing. And second is tissues from 3 or 5 different sites where we can grow the bugs or we can do the histopathology. And third is implants, where we send for sonification, especially the patient who are on antibiotics. The culture yield will be little better with sonification.
And if you're hoping to salvage the prosthesis, especially if it is a very short history and acute hematogenous, there is still a window period for salvage. Yeah. In which case, would you do a poly exchange if possible, or what is your plan in this?
Yeah, definitely poly exchange, sir. Definitely, if you think it's just an acute infection and implants are intact and there is no much tissue changes, especially the collaterals and the rest of the musculature, then I do diet, remove the poly. Not only in the fear of that poly will get attached only to the the bugs will only attach to the poly, but also to clean the posterior aspect.
Sure.
Giving a 360-degree wash, it will be helpful.
Sure.
Gait works very well in this.
Yeah.
Yeah. And secondly, you obviously would, send the tissues and all the samples of, see, I think the short history, I think, is critical here. And, most of these patients you could salvage. I generally wait 48 hours just to see if anything is growing in the samples that I've sent off. And if by then, they can tell you at least it is a gram positive or a gram negative. And many times, lab can tell you in 48 hours what growth you have. So you can actually, plan accordingly. And if it is a short history, I would still be trying to salvage that prosthesis with, everything that you mentioned just now. Let's look at this one case of, chronic low-grade infection, chronic high-grade infection. 74-year-old male patient, non-diabetic, had Pseudomonas infection for 2 years with 3 discharging sinuses, as you can see. What's your plan? One thing I needed to ask all the panelists, if you know the bug in advance, does your surgical protocol change depending on the bug that you have? Suppose you have staph epidermidis versus, say, Pseudomonas. Yeah, Vaibhav?
Yeah, of course. I mean, if I get a bug which has got a good sensitivity pattern, it's not the bug, it's the antibiotic sensitivity pattern that's important. So if your sensitivity pattern and MIC values are decent, then I would probably nowadays, I mean, I originally started doing all 2-stage revisions, but now I have moved to at least doing 10 to 15% of my things as a single stage revisions. And I hope, I mean, as our technology and our technique improves with culture, and also we have antibiotics which are much more powerful, then we'll be more inclined to do single stage with those.
Anybody else on the panel does single stage?
We are doing now, Hemant.
All right.
Yeah.
Okay. And you're happy with the results, or you're using the...
Not many cases, but we're trying to do that UK technique in 2 different theaters.
All right. So actually shifting the patient and they're doing everything afresh.
Exactly, like 2 different teams, 2 different theaters. And so...
All right.
One thing I've started doing is to get my tumor surgeon on board for these debridements. We, as an arthroplasty surgeon, are very conservative. Let me tell you, I think that's the most important thing. We can't debride them as brutally as, I mean,
as the Europeans in endoclinic. But as you heard Javed Parvezi say that they debride the collaterals.
Yes.
I went to endoclinic, stayed for 2 days.
Yeah.
You cannot do a surgery like they do. It's
that's why you have to get an onco surgeon, onco ortho surgeon. That's what I've started doing it.
So blame the onco ortho surgeon for taking away the collaterals.
No, not blame it. I said do whatever it takes to kind of completely clear it off, and then I'll enter. So
no, but I would agree with Dr. Parvezi when he said that you don't actually need to take off the collaterals. You can still work around the collaterals.
No, but they're decent people. They don't take off collateral that easily.
Right. This is the kind of picture on opening and removal of the prosthesis. It's quite scary, isn't it? Vaibhav?
Yeah. Yes, sir. Yeah.
And that's at the end of the debridement. And I had put a test. This case is again a very old case. But I love this case because, it had excellent, a lot of learning points here. A static spacer was used at the time for economy reasons. Any of you using, all of us, I think, if possible, would try to use a dynamic spacer, right? Either a Prostelac kind or cement prosthesis. Most of the times, the decision is based on economics rather than what's the optimum for the patient. And any or differing views here?
So I think we should use articulating spacers and also use these stimulant or some kind of local antibiotic delivery system.
Yeah, I mean, I use Palacos, molds to produce the prosthesis on table. Obviously, use the antibiotics that are appropriate for that. If you know the bug, it's far easier to prepare choose the antibiotics within the mold. And that was the revision done 2 months later. And again, the collaterals were good. Medial collateral was excellent. So no need to use, use a normal PS poly that was used here. And those are all the sinuses. The 3 sinuses that were there, obviously, are all healed. So I think I would stop here because it was already overrun in a big way. And thank you all. Thank you, Gaurava, for giving us an opportunity to present here.
Thank you so much, Hemant. and you can stop screen sharing. And it's a wonderful session. Arun, will you take the honors of thanking everyone?
Thank you, sir.
Arun, are you still there? I think he's gone. Okay.
Yeah, he had to log out, sir.
Okay. Yeah, Praharsha is my blue-eyed boy. Thank you so much for running it. And Manoj and Raju Vaishya, these people had to leave because they got some other commitments. But of course, we overran by 30 to 40 minutes, but that's what we expect. And we are okay with that. We got a lot of value added addition in that extra time. And thanks everyone for staying back and participating. And we will have one more great session tomorrow, and that is a hip day. It will be chaired by Sharon Patel. And President's address, I said, how to be a happy orthopedic surgeon. I'll give it tomorrow at an appropriate time. And if anybody wants to add to my talk, please join me.
Can't wait for your talk, Guruva.
Good, wonderful. And guys, be prepared for 2023 physical meeting. It's going to be in Hyderabad, April, probably. Parasha, what are the second week dates?
Around 12th to 15th in that slot.
Yeah, 12th, 13th, 14th, I think. There was a Friday, Saturday, Sunday.
Yes.
We'll have one time because 2020 was a way we really got disappointed.
Guruva, my room is still booked in the film city.
Yeah. Rajesh was also saying money is not yet returned. We'll pay it with interest, probably. Good. Thank you,
right.
guys.
Okay, sir.
And see you tomorrow. Please join us tomorrow.
Yes, sir. Thank you.
Good night. Good night, everybody. Thanks.
Goodbye.
Good night.
By the